it okay if I stand? Is it okay if I stand? Is it okay? Yeah. So, as they take their seats, what are we looking at in this panel discussion? The objective is for us to discuss opportunities within the community health systems for integration, for integrated and cross-sectoral investment for delivery of sustainable and comprehensive maternal newborn health results. We will also be looking at the level of systems inputs and strategic shifts required to accelerate community health as a key pivot for accelerating maternal newborn health outcomes. And we will be discussing some of the innovative approaches. We will be discussing innovative approaches, high impact interventions, and lessons learned necessary to optimize community health towards improved maternal and newborn health outcomes. And we have with us our delegates. You're welcome. We hope you had a nice rest, and we're looking forward to listening to you. And so I would like to introduce them. I'll introduce them as they speak, before they speak, so that we can save on time, just so you understand who is speaking and the wealth of experience they bring to the table. So I'll start with our ministry, the steward to all this program. I'll start with Dr. Hilary Atwere. And Dr. Hilary is a senior, just a minute. Dr. Hilary is a senior, just a minute. Dr. Hilary is a senior medical officer in the community health department. He has previously worked in Fort Portal at Health Center 4 and Regional Referral Hospital, as well as IMC, now CARE, C-CARE, I think C-CARE. You're welcome, Dr. Hilary. We are very excited. He's going to represent the Ministry Community Health Department, and I'll go straight to the question. Dr. Hilary, for you, what are the key community system strengthening opportunities, looking at models, investments that exist within the community health strategy that we as program implementers in the room can use or take advantage of to advance maternal newborn health outcome at community level? Can you please share with us what the Ministry and Community Health Department has for us in terms of this area of work in the system strengthening cascade? Thank you.
Thank you, Grace. I'm happy to be here. The Ministry of Health is cognizant that health is built at home, in the community really, whether it's a home, schools, or any other community setting. And so through the Community Health Department, with the support of the other departments, developed the National Community Health Strategy. And this is an approach that is intended to be multi-sectoral, because we all know that different sectors contribute to health. And so it's meant to tap into the different sectors to be able to achieve community health. And so through the Community Health Department, it's birthed the National Community Health Strategy, which we hope will be able to help the Ministry of Health to be able to mobilize resources available through partnerships with various implementing partners, and so be able to deliver community health at the community level. this strategy seeks to be able to help the ministry to map the different providers and implementing partners, and this should be able to help determine what resources can be deployed in the various community spaces. And so in this, it's envisaged that that we should be able to institutionalize community financing through public-private partnerships. However, maybe two key areas stand out in this strategy. One is to be able to build capacity of the village health teams, to be able to support them to cause engagement of the community so that they are empowered to be able to seek community health services and better the practices at the household level. And this can be leveraged by the maternal and child health interventions so that we have better outcomes. And at this level, this strategy ensures that services are integrated. And so in the process of building capacity of these village health teams, it's envisaged that we'll be able to approach households as a whole, as opposed to, say, implementing different activities that look at only only a few areas. For example, if you were to implement ICCM, it would be probably isolated from other interventions. This strategy ensures that the approach is more holistic and integrated. And so in this, we hope that we'll be able to increase demand for these community health services. And so this, we hope, can improve on the budgeting for these services, and maternal and child health interventions can leverage this to be able to achieve even better outcomes. The other key area would be because as we do the implementation, there is need to assess ourselves and be able to know how we are doing and understand in which areas we need to improve. So this strategy is intended to leverage on the electronic community health information system so that we can better understand what areas we need to work on, especially those that are key to maternal and child health. And we think that maternal child health interventions can really leverage this to be able to enhance the outcomes that and the good strides that we've already been able to achieve. Yes, so maybe to close on that is that this strategy also enables us to be able to bring all this together in order to promote and essentially prevent disease, but perhaps to better our health so that we, and in case disease does come, then this has been anchored to our already existing structure, which is facility-based, to be able to then complete the cycle.
Thank you. Thank you so much. Delegates you've had, we have a strategy. So we need to interest ourselves in understanding what this strategy is all about and how we can influence and ensure that newborn and maternal health is included, both in terms of investments, but also in their prioritization. And so, Doctor, you've highlighted critical issues and the elements or aspects in the strategy that actually we can leverage as maternal and newborn health programs. I want to put Dr. Harriet on spot now. And Dr. Harriet is currently working with UNICEF as a health officer and is based in Arua Zonal office. And she is the team lead for health at UNICEF in the Arua Zonal office. She's a pediatrician with over 10 years experience in health programming, focusing on maternal and newborn health, nutrition, comprehensive HIV, WASH, health system strengthening, both at national and subnational level. She previously worked with Baylor, Uganda. And here in our panel, she's going to speak on behalf of partners, not only UNICEF, but partners in integral manner. And I just want to throw it back to you, Harriet. You have listened to Dr. Hilary's submission about the community health strategy. Looking at partnerships, what roles do partnerships play in strengthening community health systems? And from your experience, interaction, engagement in different platforms where we're seeing partners play critical roles, what are some of the examples of successful collaborations that have improved maternal and newborn health? Over to you, Dr. Harriet.
Yeah, thank you very much, Grace, and thank you, colleagues in the House.
Is your mic on?
Yeah, hopeful that it's on.
It's better now.
Yes, so with partnerships, there are many opportunities that partnerships bring, and one of them is partnerships bring together resources that may be financial or non-financial to be able to achieve better results for health for both children and newborns and women. And these results may otherwise have been not achieved if these partners were not present to bring their different complementarities on the table. The partnerships also play a good or important role in closing health equity gaps. So they promote health equity. We've listened it, and the reason we are here today is because of the power of partnerships. Different partners in the House on the MNH agenda have come here today, and we've listened to their roles in different areas. Work that would otherwise be difficult to achieve without the partnerships. And in terms of promoting health equity, we've listened and heard. Most of these partnerships are coming in to address different vulnerabilities within our communities. And that way, we are able to provide a fair package of health care to our communities. What have been some of the excellent examples of partnerships? I'll start with the community itself. Nothing for us without us, as it's always said, especially in the HIV space. We've seen communities coming together to do different things, communities themselves driving the agenda for maternal newborn. We've listened in yesterday to examples of communities supporting blood donation drives. We've also had very good examples of communities raising funds for transport, establishing their own schemes for transportation of sick and small newborns, and also women that are pregnant or have given birth. And we have also, there are different components also of community, like parent support groups. You are all familiar with the parent support groups that have been formed around this country, one led by Mr. Basilio. There are many, and some of them just need to figure it out better. But these are helpful in supporting within the community. Of course, it's important to mention the public, where we have the largest number, which is the community health workers. And I'm sure my colleagues will be speaking later, will be strongly speaking about how the community health workers have been greatly used to good end to be able to support in promoting health for women and children in the communities. Then comes the transport agencies. The commonest in our section that we've worked with mainly around maternal newborn health is the border associations, which have been used in different ways to support transportation from community to health facility. Different regions have used these, and they have been used effectively in previous programs like Saving Mothers, Giving Life, the current programs that are running in the West Nile region in the community voucher system, where we've seen transportation of women and newborns and children under 5 from community to health facility with very good outcomes as a result of the additional support that comes through this work. We've also seen and experienced good partnerships with the private sector as a country. And the commonest example that is closest to our memories is in the recently concluded PET Awareness Month, where we saw private sector coming in different regions to support the awareness creation and the advocacy around hypertensive diseases of pregnancy. And the other is the faith-based institutions. And faith-based institutions come in different ways, sometimes providing the community support around community financing. All of you may be aware about the Kisizi Community Health Insurance, where burial groups that started as burial funeral groups now have over 40,000 membership of members of a community are running a health insurance through the work of faith-based institutions. And in addition to these faith-based institutions, we've seen awareness being created through churches, through mosques, on different maternal and newborn issues that have come up severally, and awareness is needed. And these are some of the areas where partnerships have been key. We have seen also private sector in different ways. I think one of the recent times we've had to run for babies through MTN. And those are some of the areas where we clearly can see the partnerships coming off and supporting in one or another, whether advocacy or financing, things that could otherwise have not been done if this support was not there. And then we've seen private sector come in on different ways, like we have digital platforms that have been developed to support maternal newborn health agenda, like Family Connect, delivering the key family care practices using these platforms. And these kind of platforms, electronic platforms, have been created with the support of the private sector. Of course, there are so many players that I can speak to, and I could speak until the cows come back home. But one thing that I can emphasize that we are all here, CSOs, health development partners, philanthropies, different players, academia. I mean, schools are very important. We already had. If we keep the girls in school, then we can delay some of these problems that are associated to maternal and newborn issues. So with that, I think that I can come to a close. Otherwise, there's so much that can be said. Thank you.
Very well put, Harriet. Thank you so much, Dr. Harriet, for highlighting partnerships. Sometimes we are boxed. We think inside the box. We don't think about the roads. We don't think about private sector. Even within our communities, we are thinking about just health and the clinical aspects of health. But health is beyond clinical if we are to make impact. And Harriet, thank you so much for bringing up some of these issues, the partnerships and their contribution to the work that we do. And let us also take note. I just now want to move to our friend, Henry, Lulu Henry Leko. I just want to briefly introduce him. Sir, allow me to introduce you before you can make your submission. Lulu is Mr. Lulu is a DHO, assistant DHO for maternal health, and he operates in Adjumani district, and he's played pivotal role in overseeing maternal newborn health initiatives, bringing practical community-level interventions that has strengthened the improved maternal newborn health services in Adjumani. He's the vice coordinator or the assistant chair for the local maternity, West Nile local maternity system. And then before he joined the local government, Henry was the regional manager for AIDS Information Center in both West Nile and Lango, where he managed the regional health programs, but he also worked as a manager for Better Outcomes and Dreams project. Muke?
Award 4.
Award 4. That's how far I can go. I think I'm safe that way. Looking at what Harriet has discussed, Henry, drawing from your experience, can you please tell us what you think, or from your region in West Nile, not only looking at Adjumani, but looking at West Nile, since you're even the vice chair for local maternity systems, West Nile local maternity systems, what are the most innovative and high impact innovations that have optimized community health for maternal newborn health? And as you share with us, can you also advise us on how you think this can be replicated beyond West Nile, the boundaries of West Nile region, maybe to Western or actually sub-region? Over to you, my friend.
Thank you for the kind introductions. Before I dive deeper into that subject matter, I want to take this opportunity to appreciate the government of Uganda, and especially Ministry of Health, for the enabling policy and strategic framework that has promoted open door policy, that has also strengthened public-community partnership. And we also want to appreciate the various development partners. I may not be able to have the opportunity to call you by names because you are quite many, for the tremendous contribution, especially in the strengthening of the community health programs. Why I recognize the Ministry of Health is because the engagement of the community health structures is grounded on the community health strategy, but also more importantly, which was launched more recently, the self-care program, the self-care strategy. These are very, very key strategic directions that we are taking to be able to address some of the critical maternal and newborn health issues, and those are the areas which I'll be focusing on. As the previous speakers have said, it is difficult to divorce the community health structures from the community health system from the health system, because these play complementary roles in terms of the facility, community referral, and facility community referral system. And so this is one of the things that we'll be looking at. I want to appreciate the ministry for the support, especially to Western Nile region, in helping us to operationalize the community health strategy, especially the VHTs. Adjumani is one of the lucky districts that benefited from the Ukraine project that aimed at strengthening and revitalizing the VHTs. And so we benefited a lot in terms of capacity building for our VHTs, about 720 VHTs in Adjumani district and in other 20 districts benefited from that. And this is very key because the previous VHTs were trained long time ago when we were talking about the 6 killer diseases. Today we are talking of about 13 vaccine preventable diseases, and malaria is just knocking around the corner that we'll be able to introduce this early next year. So these are very strategic areas of focus, and I can tell you therefore that the civil societies and the partners in West Nile build on the foundation that the ministry laid to revitalize the VHTs and other community structures. In Adjumani specifically, and the region, various development partners put resources to strengthen the Ministry of Health to develop the necessary standard operating procedures and guidelines for enhancing the capacity of our community health workers. Here we are specifically talking about the VHTs that are cutting across the districts. We're also talking about the community health extension workers that have been piloted, and in the West Nile, specifically in Marachawe, it is piloted in other districts. Through the support of Ministry of Health, we were able to develop standard training manuals and also guidelines to be able to enhance the capacity of these community health workers. Then, secondly, is that with this support from the partners, we were able to ensure that we collect real-time baseline data. Baseline data on the status of the community health service intervention, but also key performance indicators that needed to be addressed at the community level. Specifically in Adjumani, for example, we're able to collect data, analyze our data on VHT reporting in terms of timeliness, in terms of completeness of reporting. We're able to collect data on key maternal and newborn health indicators, and then we went to the community to engage them in assessing their knowledge, their attitude, their practices in areas of maternal and newborn health, and also other health interventions. And that was very key to enable us to be able to provide evidence-based capacity building for these VHTs. We were able to do that very well, but we also built the capacity of the district level trainers and mentors. This is the strategic approach by the development partners, so that even if the resources, funding ends, the districts are able to sustain these gains. So I can therefore report to you comfortably that we have district level trainers of trainers who are able to provide the necessary capacity building for the VHTs at the community level. And specifically talking about the multi-sectoral approach, we enhanced capacity not only in health, we enhanced capacity in the community services department, we enhanced capacity in education, Ministry of Education and Sports. So at the level of the district, we are building the capacity of the DHTs, the education officers, and the community development officers who are at the front line of service delivery, especially the ones at the sub-county level, to be able to support this. When we did this, the next level now is to build the capacity of the VHTs. And this is done by the resource persons we have at the district level, including the senior woman and the male teacher, if we talk about education. In health, we are building the capacity of midwives, of nurses, of clinical officers, a team of health workers who can be able to provide training on adolescent responsive sexual reproductive health services and GBV prevention and mitigation. We were able to then, using this, we did capacity building for VHTs. We did capacity building for peers. Harriet has highlighted. We are looking at the group ANC, for example, and group postnatal care. We are looking at the YAPs. We are looking at also health workers who are able to provide adolescent responsive health services, but also peers. The peer model is gaining momentum, and I can therefore say with confidence that we're able to build the capacities of peers in school, out of school, both therefore that helps us to be able to provide services at facility, at community, and even in schools. We trained, for example, in Adjumani, close to 100 senior women and male teachers, who in turn went and built the training of the mentors, the peers in schools, to be able to provide sexual reproductive health education, and be able to empower people to appreciate their sexual reproductive health rights, be able to hold the duty bearers accountable and demand for services. We were able to also inform them of the availability and existence of these services in our various facilities, in the communities. With the support of partners, we mapped key community hotspots where the key drivers of the challenges of adolescents. Talk about teenage pregnancy, talk about alcohol and substance abuse. We're able to map these spots. We're able to engage the community in dialogues so that we're able to get solutions. In the local maternity, we usually say, local problems require local solutions. So we go, for example, the subject of teenage pregnancy. We go and sit on the round table with the young people represented, with the political leaders, with the religious leaders, with cultural leaders, with the police, family, and child protection unit, with education officers, with health workers, we are able to examine what is this that is driving some of these challenges. Alcohol and substance abuse, the increase in road traffic accidents affecting young people, teenage pregnancy, all this we discuss, and we're able to get local solutions to these challenges. And then also what has worked very well in West Nile, and especially in Adjumani, is engaging the community health structures in health education and health promotion. We have empowered this team to go home to home. The VHT is going home to mobilize people, to sensitize them, and you have all seen, even in the CAST Plus, where we integrate HIV, TB screening, nutrition screening, and all these challenges. We're able to onboard these people so that they are the first line, frontline officers who go to educate community on some of these diseases of public health importance, and arising from here, they're able to make effective referral and a linkage to our facilities. We have also seen communities being engaged in self-care programs. With the support of UNICEF, we are in the kitchen, we are trying to cook something in Adjumani and in Amudat, particularly caring for caregivers. This is a pilot, a mental health and a support initiative to empower caregivers to be able to, first of all, identify the challenges that it goes through with caregiving, but also to empower them with the support of VHTs to be able to address some of these challenges. And this is a big partnership. Ministry of Health, Makerere University, University of Wits in South Africa, UNICEF, the district local governments, the Ministry of Health, the Ministry of Education, we are trying to do that. And already we are seeing the promising results. This is informed by evidence. When we did the maternal and newborn quality of care assessment using the digitized World Health Organization standards, the 80s quality standards, we noted that mental health has been one of the poorly performing indicators. Actually, indicators that deal with mother's experience of care, right from effective communication, respect and dignity, and then, more importantly, the mental health are indicators that we're not doing well. And so with this, that we are cooking in the kitchen, our belief is that, and with the results that we are seeing, the preliminary results, we are seeing that that could be an innovative area that we can scale up. We have seen improvement in referrals. When we did the assessment, we have seen progressive improvement when VHTs go to homes, identify mothers that have risks. Currently, we're implementing the IRR. IRR is identification, referral for lower BMOC facilities, but also retention in the CMOC facilities, and timely response to some of these emergencies. It is something that is working very well in a number of selected facilities, especially in Adjumani, in a facility called Mongola. We are doing a very tremendous job. Those are initiatives that can help because we put the community structures at the forefront of identifying this. When they go to homes during their home visits, they identify high-risk mothers. They ensure that these high-risk mothers are walked to the health center and handed over to health service providers. And from there, we're able to see that lower-level facilities that realize that this is a problem beyond their scope. They're able to refer from these spoke sites to the hubs. The hubs are the CMOC facilities, the health center force, the general hospitals, and the regional referral hospital that has dedicated days for attending to high-risk mothers, which is done by a medical officer, by a midwife, by a laboratory technician, by a sonographer. So we have a multidisciplinary team that is able to work on these matters, and we already seen positive outcomes from those initiatives that are worth replicating to other districts.
And finally?
The story is long, but let me now address myself. Let me address myself to provision of basic health services. We are all aware that under the self-care program, Ministry of Health is promoting particularly the subcutaneous injection as a family planning method that it gives the responsibility of protection and also preventing teenage pregnancy in the hands of these adolescents and young people. In Adjumani specifically, I want to say this is paying off. We started when our contraceptive prevalence was only 22.7%. In the last 3 years, we have moved to increasing contraceptive prevalence, to 48.6%. And I think we are currently the district that has increased family planning uptake by a bigger margin. And I think we are on a track to achieve the family planning target 2020. I think that is one of the critical areas. Also in areas of teenage pregnancy, because of this intervention at the community level, the community dialogues, the engagement of communities to appreciate the importance of family planning, especially the immediate postpartum family planning, we are also getting a dividends. In Germany, currently our teenage pregnancy is at 15% compared to the national average of 24%. And I think there is therefore a lot of positive lessons that we are learning from there. In terms of the system, I cannot leave this. During the adolescent conference, the Permanent Secretary Ministry of Health officially launched the guideline for the operationalization of the district community committee on adolescent health. I want to say, with the support of development partners, we embraced that long time ago. Currently, as we talk, we are flying as a district because we have a functional district committee on adolescent health that sets plans, that is able to go and supervise delivery of adolescent health services at the community, at the facility and at the community level, that is able to come back on the drawing board to have a multi-sectoral dialogue guided by data. We extract data from DHS2, we get data from the community service department, we get data from education, to be able to track the critical adolescent health indicators, and where we are not doing well, we are going to get back to the community with the support of their leaders to ensure that we address these gaps.
Thank you so much, Henry. Colleagues, the story is indeed long, and I hope West Nile has been well represented, and I hope it's a true reflection of what's happening. As UNICEF, we are very proud of West Nile and all the stakeholders within the region, and we're also very proud of Ajumani. He's spoken about partner issues, a multi-sectoral approach, integration, and we can see the passion that he has. He could go on and on and on. But allow me now to move to the next presenter. Where are the midwives in the house? Ooh, we have not forgotten you. And in a special way, allow me to read this. I know time is up, Chair. MC, but allow me, we are only left with one panelist after this. Allow me to read this profile, midwives, so that you can also get inspired. So with us, we have our midwife. She's Courtney, Sister Courtney, and Achiganda. She's a devoted and passionate midwife. You can see even from the age, retired but not tired. She brings 40 years of experience in facility and community-based care, and she has spent much of her career working with Chiwoko Hospital as a midwife. She is currently running a hospital-to-home program with Adara. As a community midwife, Courtney manages a large group of 120 village health team members and provides at-home follow-up care for high-risk babies for up to a year after discharge from Chiwoko Hospital and neonatal care unit. And she comes with the home-to-home, the first newborn follow-up program. It's one of its kind in Uganda, and I think we've also heard from the other presenters, they've highlighted elements of this model in their presentation. Courtney's contribution as a midwife has transformed the way care is delivered to vulnerable newborns and their families in the community. In 2021, to crown it all before she can speak, in 2021, Courtney was the finalist in the Midwife of the Year category at Ugandan Hero in Health Awards. In 2020, she was honored as one of the women in the Global Health's 100 Outstanding Nurses and Midwives. And then in 2019, the profile, please make a profile for yourselves, so that even when you retire, people remember you. Lastly, Courtney was named, in 2019, she was named as a newborn champion by the Ministry of Health for her dedication to vulnerable newborns newborns and their families. So Courtney, you're very welcome. We are so proud of you. What a profile. So I will go to the question, so to save time. Given your experience working in the community, how can community empowerment be sustainably achieved to reduce newborn mortality? Please, using your experience, first-hand experience, please share with us your experience, ma'am.
Thank you, moderator. I appreciate to be here. I'm going to use the hospital to home program to answer the question. Hospital to home program is a follow-up program on babies, on small sick babies who are discharged currently from Chiwoko Hospital. And to make sure they thrive, they survive and thrive. The hospital to home program was started, it was initiated in 2019 after a research which showed that babies were not returning after discharge. They were not returning to the health facility for follow-up. It was found that only 30% were coming back to the health facility. So we had to go and look for the 70. We are working now in the community. We are following up these babies after discharge. We have two components in our program. We have the hospital component and we have the community part. I'm going to talk more about the community. But in the hospital, once the babies are admitted, during their stay in the hospital, they are given a discharge package, which include the topics like kangaroo mother care, breastfeeding, hygiene, identification of danger signs by the mothers, so that babies don't die. So once they are discharged, before they are discharged, they are linked to the community. The discharge staff links the mother to the village health team. This village health team, they are VHTs who are in the community. They are a part of their communities, so they were the right people we chose to use in the implementation of our follow-up program on these babies. This village health team, I work with the 120 village health team, and we work in 3 districts, Nakasongola and Nakaseke, and Ruwero. These village health teams were equipped with the knowledge and skills, basic knowledge and skills to care for the newborn babies. And they were equipped with a backpack and all equipment needed for the baby's examination. They were given weighing scales, they were given timers, thermometers, and they weigh these babies whenever they go there. What do? These VHTs. They do home visits, and once they visit these babies, they do growth monitoring, breastfeeding assessments, they educate the mothers, the families, not only mothers, but the families. They educate on relevant topics, like the KMC, again, breastfeeding. At first, these mothers, after leaving the hospital, they were not continuing to express breast milk. and this killed so many babies. They were stopping to breastfeed. They were putting these tiny babies on the breasts, thinking that they were taking milk, but there was nothing. So these babies used to die. So supervision of the breastfeeding now has made them survive. When these VHTs, before they go to the community, the VHTs, they have to visit the local councils. They report to the local councils that I have come to visit such and such a person who is having a baby, a small sick newborn. So we work hand in hand with the local councils. They help us to identify, to locate the families where these mothers stay. They also, not only the mothers, they don't only visit mothers, but they health educate the whole community about prevention of premature deliveries, prevention of hygiene, prevention of diseases, and they are also consulted. The community consults them. So being in the community, in their own community, this empowers the community to accept, to access, and to utilize the health care in their areas. Because these people, they do a very good job. They are influencers of the community, the VHTs. So when these mothers are educated, visited, they continue looking after their babies very well. We get live babies. And what they do also, they identify danger signs. And once any danger sign is identified, the babies are referred to health facilities, or if the baby is having a developmental disability, the baby is referred to Baby Ubuntu. Baby Ubuntu is our sister program which helps the babies with the disabilities to live a better life. So we have the Baby Ubuntu where we refer our babies once identified with the developmental disabilities. The community has to be involved in every activity. If anyone wants to anyone wants to implement a program, he has to involve the community. The community has to be involved, and the community members have to participate in the program so that they own it as their own. Owning that program, it will continue even if the implementers go, because they will know it is their program and it is their own health, it is their own babies, so they have to work to accept it in the community so that the babies survive and thrive.
Thank you.
And these VHTs, the community leaders, the LOCs, they mobilize for transportation of these babies to the health facility. They mobilize the community to contribute money to give to the mothers, the mothers who are not able to raise up funds for transport. So we also collaborate with the Ministry of Health, the district, the sub-counties, the health facility in charges. We collaborate so that we do things together.
Thank you
we
so
cannot
much.
work alone.
Thank you so much, sister. I know
Let
when
me
given
conclude.
time,
Let me conclude. conclude.
you know, we all speak when it's an area of our passion. We want to put our hearts on the table. So, okay, finally.
Yeah. Currently, we are piloting the H2H program in the public setting, and we hope it will work. We have just started, we will be telling you the results. So, community engagement is very important. It empowers the community, it sustains the interventions, and if we do it, all babies will survive and they will thrive.
Well said. Well said. I can't say more. I think she highlights one of the critical areas that we all miss in our programs. We celebrate so many newborns, preterms, discharged from our facilities. But when they go back, do they survive? And what is the quality of life if they survive? Many of them survive with disabilities, and we know what disability is. If you have a child with disability, it's very painful and very expensive to manage these children, especially when you don't have a good support system. I would now like to ask to put ice on the cake as we wind up. I'm sorry that we are a bit not doing so well in time, but this is our last presenter, and she is Dr. Elizabeth Ekirapa. She is an accomplished public health expert with 15 years of distinguished performance, and she is an associate professor at the Department of Public Policy Planning and Management at Makerere University. She's a medical doctor. She also has masters in health economics, a doctorate in health systems research from Trinity College, Dublin. You're welcome, Doctor, and we're excited to have you. So from the academic and research perspective, Doctor, can you tell us how research, innovations, and emerging knowledge on community health can be leveraged to accelerate reduction of newborn mortality, and what are the promising advancements? Tell us what the promising advancements are showing in terms of what will give us most potential when we invest at community level. Thank you. Over to you, Ma'am.
Thank you. Thank you so much, Grace. So when we think about community systems, we are thinking about using organized structures and processes to help us deliver the services. But we are also thinking about integrating these services with community needs and resources. And so the first thing I want to say is that we need to link research more with the service delivery that we do. And talking about what are some of the interventions that we could be able to look at, that we could be able to utilize. I think we've already had so many of these interventions. I won't go into so many of them, but we already know these interventions. We know about the potential of KMC. We know about the potential of things like mHealth. We know about how we could utilize telemedicine. We know about how we could utilize simulation models for training. When I was training as a doctor, we didn't have these simulation models. So if you were doing a breech delivery, you'd go and practice on a live baby who could very easily come out dead. That doesn't have to be the situation now. We have these simulation models. So there are a lot of interventions around us. But what's the challenge? We tend not to scale up these innovations. So research can help us to find out how best to scale up these innovations. I also want to emphasize the issue of offering a package of interventions. Sometimes we want to just, provide specific things. But if you're in a household, you don't live your life in those packages. You live your life holistically. So when we think about research, when we think about what we need to do, we need to promote interventions that are multifaceted, interventions that are integrated, so that we can address the different aspects of the newborn's life that we need to address. But we also need to contextualize these things that we do. Henry mentioned that local problems need local solutions. So as we think about using research, we need to use those research and innovations that we think or we know are cost effective. We need to contextualize them. And I want to emphasize 3 areas. We need to think more about how we deliver the different services. If we think about making preterm services, services for preterm babies available, you're not going to succeed if you're using the same model to deliver preterm services to an urban, rural woman who has to work daily to have an income, like you're going to use to deliver services to an upscale corporate woman who can go to Nakasero Hospital, or to the wife of a nomadic herdsman somewhere in the middle of Karamoja. Sometimes we use service delivery models that are like one size fits all. We need to be able to contextualize these models to the different communities and settings where we are. We also need to think more about who am I targeting? Whom do I need to be focusing on? Who are the newborns who are dying? Who are those who are being born as preterms? Who are those who are getting birth asphyxia? Where are the hotspots for these different mortalities? We can do research that help us identify that. And then how can we actually target some of these particular vulnerable groups or locations where we want to focus? You can use things like vouchers to help you target those groups. You can use the example of Adara, like we've just been hearing about, to follow up those newborns who used not to go to the facility. So we need to contextualize and ensure that we provide those services where they're needed. But sometimes we find that we do not have the solutions and the innovations that we need. And so we need to be thinking where the areas where we don't have solutions. We know that sepsis is one of the common causes of newborn mortality. Do we have the diagnostics that can help us be able to diagnose sepsis at the community level? What can we do to support the development of these diagnostics? We also need to do research that is going to promote data-driven decision-making. We are talking about community health information systems. How can we do research that can help us provide information that a sub-county chief can be able to use? That a sub-county chief can be able to see that we lost 30 newborns last year. We lost 40 the previous year. We want to lose 20 next year. No, not that we want to lose, but we want to make sure we reduce that number. What do we need to do? Can we do research that can provide such information? From the examples we've had, we've seen that we need communities at the center of these systems. We need districts actually taking the initiative to organize these services. For them to be able to do that, they need this kind of data. We also need to embrace more of predictive analytics. Can we predict that this mother is likely to have a preterm birth? Who are the mothers who end up with preterm births? Can we identify them during antenatal care so that we focus more on them? When a newborn is born, can we identify those who are likely to have complications? Can we focus on them, give them the information, follow them up, make sure they come back to the facility, or we go to the community to follow them up? As I draw to a close, the issue of funding this research, a lot of the research that we do in academia is funded externally and meets the interests of those who put out these calls. So we need to also fund our own local research. We need to own this research. We need to have a research agenda. When we talk about newborn health and trying to reduce this, where do we want to focus our research efforts? I want to appreciate the government. The government is currently giving money to Makerere under the Research and Innovations Fund. As Ministry of Health, do we go to Makerere and we say, government is giving you this money, this is what we are struggling with, we want you to do research on this? Or do we just allow that money to be used for different things? So we need to own the research that we do, we need to fund it, we need to make sure that we utilize it so that we scale up all these good models that we've been hearing about from this panel and out there. Lastly is the issue of critical partnerships and collaborations. research can also help us to identify these critical partnerships and collaborations. At the national level, with development partners, we need those partnerships that are going to help us put in place policies that are going to support these efforts towards reducing newborn death. We also need partners who are going to allocate resources towards that. Grace said we are currently writing an investment case for helping sick and small newborns. That's an investment case that needs to be funded, but who are the partners we need to go to? When you do social network analysis, that's a branch of research that you can be able to do that can help you identify some of these partners. But what about a district and community level? Who are the people we need to be partnering with? Who are the people we need to work with, to reduce teenage pregnancy, to make sure that the facilities are providing quality care, to make sure that the district, the sub-county, is allocating resources the way they should? Who are the people we need to be working with in the households, and how should we be working with them? Research can help us to be able to do that more effectively. How about the local resources? When we talk about community health systems, I said we are thinking about integrating services with the resources that we have. How are we using the locally existing structures that we have? In our communities, we have circles. We did some research where people were able to use these circles to save money that the mother could be able to use to transport herself or transport her baby to the facility. These circles can provide a social network that can be able to support mothers who are going through a difficult time. These circles can provide a network that can support mothers who are doing KMC. How are we using these circles? How are we using the borders to help us improve transport? Lastly, social accountability. We did research around community scorecards, and we're able to see that you can use community scorecards to hold households accountable. Should a man simply have 3, 4, 5 wives and give birth to 45, 20 children whom he cannot care for? Should that woman have 10 children? How can we engage households to make sure that they're also responsible? They're ensuring that this pregnant woman is going to be able to give birth in a facility, that newborn will be able to be born safe. How can we hold the health facilities accountable? We found the community scorecards could be able to help us do that. How can we hold the leaders accountable to make sure that they're allocating resources? So if we think about research and we think about innovations, we can be able to link research and service delivery. And I want to conclude by saying we need to promote research that is multifaceted, and we need to complement that with political and community advocacy that is going to ensure that we have optimal data-driven resource allocation at the national level, at the subnational level, but also at the household level to enable us to be able to address the challenges and the problems that cause us to have this high newborn mortality that we've been talking about. Thank you.
Wow. What a wonderful way, what a nice way to wrap it up. Thank you so much, Dr. Elizabeth. I will not belabor to repeat what you have said in the interest of time, but you have crowned it all so well. Thank you. MC, I just want to ask for 2 questions from the audience. Just 2 questions, and then if you have any other burning questions to any of the panelists, you can engage. We are still here together outside of this. So any 2 burning questions from the audience from what you have heard that you would want to fire at any one of them? Henry is laughing.
Thank you so much. My question goes to Mr. Leku Henry. You mentioned that one of the achievements that have reduced teenage pregnancies is the increase in the contraceptive use among teenage girls. But I would like to ask, have you considered the fact that a lot of the pregnancies are defilement cases, and so have you involved enforcing the law to curb a lot of these development cases? Yeah.
The second question.
Okay, thank you so much. I appreciate the submissions of the colleagues, and I would want to address this to Dr. Hilary. having learned that in the past we had community health extension workers almost rolled out throughout the country in 2018. Then we had some hiccups, and this was called off, I could say, and now ministry began again the processes of rolling it around the country. Can you tell us what lessons have we learned from what had happened in the past that maybe those gaps, if addressed, can make us again prevent us backsliding and saying that next time we shall have this activity done? And finally, how can we tease out maternal and child health to come out clearly in the community health agenda? Thank you very much.
Thank you. I will ask for only 2 questions in the interest of time. Somebody's putting up their hand. MC, do you think? Okay, just I'm using my power to just give that one of the delegates only. Allow me to use my power. When you're in the seat, you take advantage, so let it go to him. One of the delegates, and that will be it. Then we'll respond and we wrap up the session. And as you provide your responses, let's be short. Let's not speak too long because we're already done with our time. Thank you.
Thank you. Good morning. My name is Rogers Wandera. I come from Kaimpa Division, KCCA. I just had 2 questions to Sister Konet. I think I got the name right. One is, how are you able to mobilize, sustain, and facilitate the PhDs that you are working with? I just wanted that to come out. Then 2, I also wanted to see in your presentation something to do with the integration with other child interventions like nutrition. Thank you.
Okay, I think now we can go over to Henry first, then Hillary, and then we'll wind it up with Sister Connie.
Thank you. Thank you so much. One of the key things that has helped us, as I said earlier, to address the high teenage pregnancy was number 1, the community dialogues that we have held with the key stakeholders, but also arising from this community level interactions, we're able to identify the key drivers of teenage pregnancy. We're able to map hotspots, and arising from the presentation of this data to the district committee on adolescent health, which is a multi-sectoral team that has the police, it has also the resident state attorney and the magistrate sitting and to provide legal guidance, and also the political leaders who are involved in the legislation. The district is able to formulate ordinance on health, ordinance on education, ordinance on production, and ordinance on environmental protection. The police that attends this function and the local council leadership are able to shut down some of these major community level drivers of teenage pregnancy, like the late markets have been regulated, the discos that are played in every household in community level during either introduction ceremonies, during wedding, that are rampant all over the place are being regulated, and you don't just do it. So I will not point, therefore, at that, but in terms of enforcement, therefore, I must say the leadership are implementing this ordinance to the latter. That has paid off. Thank you.
Thank you. Thank you for that short response to the point. Dr. Hillary, over to you.
Maybe to start with the gaps or the challenge with the community health workers. Well, I don't know if it would be a gap, but previously the VHTs were and are probably still mostly operating on a voluntary basis. And so the community health workers, we thought that they would introduce a cadre that can be compensated, and they are able to carry out the community health interventions perhaps better. And so the idea is, and probably previously, we probably lacked a strategy as well on how to entrench the community health workers, how to bring them on board to be able to fit into the structure at that time. So what this strategy does is that it provides a space for the community health workers, but also backs it up with an entire strategy so that the community health workers are able to provide support for the VHTs at the village level, and the community health workers can feed in at the parish level, which has not been so well utilized in the community space. And that can better anchor the entire community health system to the facilities to enable that linkage and coordination. Maybe to address the question on
how we can make maternal newborn health salient in the community health strategy.
Yes, sorry. So the strategy, as I mentioned earlier, and as the previous speakers have been mentioning, and has come up with a model that is integrated, and that integrated essential community health service package has broken down different community health services for each group by age group, and there is services that are catering to and addressing the maternal health. There are services that are addressing the child health as well as the newborn care. And so under there, we think that maternal child health can leverage that, but while looking at the broader sense of the community that interacts with the newborn and mothers.
Thank you. Thank you. And lastly, Sister Kone, how have we sustained the VHTs? And yeah, in just 1 or 2 minutes, max.
Yeah. We don't work alone as H2H to mobilize the community for community sensitization meetings. We work with the DHE, the district health educators of the districts where we serve, and the health assistants, plus the local leaders of those areas where we go for the meetings. Those people, our VHTs, they also mobilize, so people attend in great numbers. And to sustain the VHTs, we don't give them salaries. They are volunteers, and we only give them incentives. We give them bicycles for transport, and we give them T-shirts for identification in the community. We give them raincoats, gumboots, and umbrellas to use. And those are the only things we give them, but we don't pay them. Yeah.
Thank you. Thank you so much. Join me to applaud the team. Thank you so much, delegates. Can you please have your seats? And I hand over to the MC. Thank you for this opportunity. Over to you.
Ladies and gentlemen, a round of applause to our very powerful chair for this session. Grace, you have done an amazing job. Thank you very much indeed. Another round of applause to the panelists. I think that has been very, very powerful. Very, very powerful. And without any further ado, ladies and gentlemen, allow me recognize in our midst Honorable Josephine Bebona. Now, important to note, Honorable Josephine is a midwife. So I expect all the midwives in this room to say something about Honorable Josephine Bebona. Thank you. Not only that, but Honorable Josephine, she's a woman member of Parliament of Bundibujo. Important to note, she's a member of the Health Committee of Parliament, and very, very importantly, she's the chair of the Parliamentary Committee for Safe Motherhood. A round of applause for Honorable Josephine, ladies and gentlemen. Excellent. At this juncture, I want us to throw 30 minutes into our break tea. Our next session is going to begin at exactly 11:30. Our tea is down, so let's stand slowly as we walk through the stores, we walk through the poster presentations, we go quickly, grab a bite, and come back so that by 30 minutes past 11, we are starting another very momentous session. I thank you. We have done over the past 5 years, and with support from other stakeholders and partners. Now, if you have a phone and you see that your neighbor is not yet in here, just pull out that phone, give them a ring, because it's not a session any person should miss, so that they are here in time. Just do that quickly. Just call your neighbor so that they're here with us and we start the ball rolling. So for those who have the program right before you, we will be listening to a presentation on strengthening urban health systems and governance for improved outcomes for women and children. And that will be presented by Dr. Nathan Tumwesije. After his presentation, we shall get a presentation on collaborating to implement RAMCA strategies and guidelines for high-impact interventions at national and subnational level, and that will be presented by none other than Miss Agnes Namagembe. And then we will share with you a video story of what we're talking about. We shall be attaching some video to the audio. And thereafter, we shall delve into the Kampala data-driven approach to enhancing urban RAMCA and nutrition services. Ever since we started these powerful conversations at this 4th National Safe Motherhood Conference, one of the things that has come out very, very strongly is our data-driven approach. And I really want us to really pay critical attention on the presentation that Dr. Richard will make on the Kampala data-driven approaches to enhance urban RAMCA and nutrition services. And it's very important to note that for the time USAID MCHN has been with us, there are a number of partners and stakeholders that they have worked with. And this is a time that we shall also recognize those incredible people that have supported the work for USAID MCHN activity. And we shall close with some very powerful remarks from our chief guest of this session, from remarks from a representative from USAID, Office Director for Health and HIV, USAID Mission. And then we shall get remarks from our chief guest for this session, who is none other than the chair for the Parliamentary Committee on Safe Motherhood, who is a midwife just like us. So, and then we shall launch the incredible documents that we have, which are targeting newborn. And as remember yesterday, we want to see that our efforts on newborn care improves quite significantly. Now, it's important for me to note that the documents that we're going to launch today, they're very critical. And we shall have 2 launches for these documents. So we shall undertake the first launch in this session today, and then we shall undertake another launch during the closeout ceremony tomorrow during the National Safe Motherhood Awards dinner, where we shall have both the Permanent Secretary and the DG with us. But today, we want you to appreciate what the contents of these documents is, and to ensure that when you go back with them, you put them to very good use. Now, without any further ado, allow me invite our very first speaker for this session, who is going to share with us strengthening urban health systems and governance for improved outcomes for women and children, and that's none other than Dr. Nathan Tumwesije, the Chief of Party, USAID Research and Activity. Dr. Nathan, the floor is yours.
Still morning. Good morning, colleagues, ladies and gentlemen. I will stand on the existing protocol to move forward. The next couple of minutes, 7 to 10, I'll share the few but very critical things we have been working with together with various government actors, our host government, Ministry of Health, and other government structures to pull momentum and achieve milestones in improving outcomes for the woman and child in Uganda, but also particularly in Kampala. Next slide. Should I move them myself? Does this work?
This is for forward, and this is back.
This one? Yeah. Okay. Yeah, thank you. The USAID Maternal Child Health and Nutrition Activity is a 5-year project. It actually ends at the end of December this year, so we have exactly 2 months remaining to the end. And so we've been in this space for almost 5 years. The aim of this project, which we call activity in the USAID speak, is to improve maternal newborn child health and nutrition outcomes in the country through various initiatives, and these are the project objectives actually. Rollout of key maternal newborn child health and nutrition strategies, guidelines, tools, training, packages, and priority high impact interventions at national level as well as at subnational level, district, healthcare facility, and community level. Another arm is to strengthen, and we've been working on this, we've been working hand in glove with our government counterparts to strengthen coordination and linkages within and between various sectors and their structures, including technical working groups, departments, divisions, etc. We've worked hard at increasing use of data for planning, decision-making, and learning at all levels, including ensuring that this is really mainstreamed and is institutionalized, and we'll be looking at some of the examples around this area. In Kampala in particular, so what I've described above is at national level, Ministry of Health and Office of the Prime Minister, and other ministries, departments, and agencies that work with these 2 ministries. But in Kampala, capital city, the smaller Kampala, that excludes Wakiso and Mukono, we've been working with the various actors in this space, in the public and private sectors, to strengthen delivery of services, maternal newborn, child health, nutrition, postpartum family planning, and of course, general health systems cross-cutting areas. We have also had an opportunity to work in the area of global health security to contribute to the Ebola response, as well as contribute to the COVID-19 response. The program areas, I have already touched on them: reproductive, maternal, newborn, child health, family planning. And family planning, we've been focusing mostly on postpartum family planning, immediate postpartum, 48 hours, 6 weeks. Gender, youth, and social inclusion as a cross-cutting area. WASH, health system strengthening. I've talked about global health security. Okay, I don't see a signal here. I don't want to read here. I want to be guided. Ah, it has come through. So as we wait for this to come through, we've walked the journey along with the Ministry of Health, and I'm going to begin with appreciation. And this is a bit unconventional. This should be at the end, but I want to begin with that. My system is not working, so if you can get me my laptop. Let me work from here. So, appreciation. First, USAID. And I'm beginning with USAID because USAID, first of all, has provided us with the funding to do this work, but also the design of this project was unique. One, it provided us with two arms at national level, but at the same time at site level, district and site level in Kampala. That provided a unique opportunity whereby we would experiment initiatives we are designing together with the ministry at the national level, right in Kampala, and would quickly learn from implementation and go back and tweak the policies and guidelines at the national level. So that kind of design provided these opportunities, and it's unique, and so we do appreciate USAID that did this. The second issue is that USAID provided us with ongoing technical support. We walked the journey together with USAID every day, every week, every month. And that helped us a lot because we were able to quickly demonstrate where we are meeting challenges and difficulties, and we are given room to quickly adapt and change direction to be appropriately responsive to the needs of the host government and the respective structures within Kampala at facility as well as community level. So we do appreciate USAID's substantial involvement in this work. A big hand clap. Ministry of Health. Now, we came a long journey with the Ministry of Health. We started this activity in 2020, and as soon as USAID introduced us to the government structures, we went into COVID-19 lockdown. But the ministry quickly adapted. We did the bulk of the work in the first 2 years virtually. I remember very well with our USAID colleagues, the entry meeting with the Office of the Prime Minister, we did it virtually. The entry meeting with KCCA, we did it virtually. And you can imagine how difficult that was. But the ministry was able to stand with us through the journey, and we provided the logistics to make sure that that happened. The ministry also provided room for us to be adaptive and to do business in an unusual way, in unusual ways. And because of that, we were able to literally rock the boat most of the time. We pushed ourselves beyond boundaries We could have caused discomfort here and there, but it was all in the interests of the results to have the woman and child be served. But we do appreciate the ministry's commitment. This thing has gone back. Going back to the previous one, it doesn't come through. Oh, here it does. Now, top leadership involvement. I wish the permanent secretary was here. As we dived into making sure that we change the way of doing business, at one point, we spent 5 months having the permanent secretary of the Ministry of Health doing with us weekly Monday morning ward rounds in one of the hospitals in this city to make sure that we actually cause change. That is a bit unusual. Clinical ward rounds with us, together with the hospital teams, top management would be there. Permanent Secretary, Director General, commissioners. Every Monday, 7 a.m., we would start our ward rounds by reviewing data of the previous week, deliveries, deaths, those who have survived, events. And we would do that on a weekly basis for 5 months. And that caused the shift. We do appreciate the top involvement of the Ministry of Health. Sorry, involvement of top leadership. Now, with this approach of doing business unusual and pushing ourselves and everybody beyond the usual boundaries, we are able to move various initiatives. The MPDSR policy was already in existence. And thank God, and we appreciate the Minister of Health for having put this in place as early as 2017, if I can remember. Now, we had to use that policy to actually move to the next step, to functionalize it, to actionalize that MPDSR policy. And so we went into a data-driven approach. Fortunately, the ministry had set up the M-Track system, which had data already mined, scattered there, and went into making sure that we generate these weekly analytics working with the ministry teams. I want to appreciate the various individuals that we worked with at the Ministry of Health to be able to move this MPDSR agenda. I remember the first presentation we actually made was in April 2020 during lockdown. At that time, there were no movements. We were working remotely, pick data, analyze, and try to convene the whole country to actually begin doing this on a weekly basis. I remember I did the presentation myself. And this was an opportunity for us to begin working in an unusual way. Initially, we had to buy data, get people's phones and send them data so that they can log into these meetings. And we did that for 2 months. And then we pushed back and let go a bit. It dipped a bit and then picked up. Now that has been mainstreamed, institutionalized, and every participant who logs on, I think last week we had 700 participants, buys their own data. I don't know whether the government gives them the money or they use personal money. I really appreciate, and I know most of you who are here actually participate in that forum, in that platform. Can we give ourselves another round of applause? Because we've been able to bring the whole country together every week without forcing anybody. 7 a.m., people have woken up, and 7:30, the business begins. For me, this is an achievement in terms of mainstreaming, institutionalization, and sustainability. MCHN activity is ending. This is going to continue, whether USAID investment is there or not. And for me, this is a major milestone. JP, I want to single out JP And I want you to stand up for recognition and a clap. And I'm not going to, sort of call upon many individuals. You can sit, sir. But it has been rewarding working with JP because he enabled us to push beyond all possible boundaries that you can think about. And that time, JP was a student doing obstetrics and gynecology. He hadn't graduated yet. Would hold meetings in Women's Hospital, in Kawempe, wherever he would be. If Dr. Makanga is here, is Dr. Makanga here? Probably not, retired commissioner. You know where we came from. So we do really appreciate your involvement. Thank you. The LMNS, I don't know whether you know how LMNS started. It was a conversation between myself and JP, and he gave it a name. And the whole thinking was about accountability. How can we have an accountability framework that drives itself? And I shared with him that when we worked in Busoga under PEPFAR, we used to have monthly breakfast meetings with districts, local government leadership, RDC, LC5, COW, with simple dashboards. How many men circumcised? 3. How many mothers died? 1. So I said, JP, your idea is good. Can we move it? So he gave it a name. Then he started asking for support, and I couldn't give him the support because LMNS is not a government structure. At that time, it was not a government structure. But we quickly went to the PS and said, we need an instrument because this structure, and people are like, what is this? We've never seen it in any government policy. And the PS actually caused that instrument to happen. And as you can see, in each region, we are able to pull voices for everybody. The resources are there, meager but there. Resources in terms of humans, time, brains, but also funding at district level, regional referral, etc. And this LMNS is supposed to pull all those so that local solutions actually are designed for local problems. So we really appreciate the milestone around this. And in Kampala, for the urban area, we quickly moved these experiments and lessons, MPDSR, data-driven, weekly, LMNS, accountability, to Kampala. And we've seen how we've been able to move rapidly within Kampala. I'll be talking about more about Kampala later on. So OPM, I haven't talked about OPM, and maybe you may be wondering what we've been doing at OPM. So OPM hosts the multi-sectoral nutrition programming platform, and so we're also in that space, helping OPM to push the various agenda for nutrition-sensitive programming. We have nutrition-specific, nutrition-sensitive programming. I think Sarah Ngarombi and somebody who are here, they understand this. Whereas the Ministry of Health spearheads interventions for nutrition-specific interventions, others are actually spearheaded by other ministries, departments, and agencies for the government of Uganda. And so we're helping OPM to advance this agenda. And we do appreciate for the work that we are doing with the multi-sector nutrition platform at the Office of the Prime Minister and the various ministries, agencies, and departments that are involved in this agenda. KCCA. We have colleagues here from KCCA. Dr. Wundo, can you stand up? A huge round of applause. So Dr. Wundo is the Division Medical Officer supervising Nakawa Division, representing the Director for Public Health and Environment for KCCA. The teams at the City Hall as well as the divisions, we do appreciate your leadership. You actually taught us a little more about district-led programming. We thought we knew it, where the district is at the forefront of planning, design, implementation, tracking, monitoring, documentation. You showed us the way, and we catalyzed what you desired, both for reproductive maternal newborn child health, but also for COVID-19 vaccination, as well as Ebola response. A round of applause to KCCA. Referral hospitals, and these are few actually, and I can mention them. Kawempe National Referral, Mulago National Referral for actually child health. We've done a lot of work in child health at Mulago National Referral. We have Naguru Regional Referral, those are public. We have public health facilities that are directly governed by KCCA, the large health centers, the smaller health centers that are public. We have community structures. We dived into urban community health, a very, very complex area, and we've done a bit of learning there, and a lot still needs to be done. And Richard will be sharing some of the achievements we've registered. Private sector, very important in Kampala. About 98% of the facilities in the city are actually private. So the bulk of the facilities are private. And believe me, the privates we are talking about are not Nakasero, Case Clinic, Kololo Hospital. We are also talking about those private healthcare facilities that have one nurse or assistant nurse, located mostly in communities that are under-resourced, underserved, but they actually do a lot of work and they generate a lot of volumes. We do appreciate your openness to actually work with an institution, a project that traditionally would be working with public facilities. And we've registered success and some good results. A round of applause for private actors. And I cannot forget Uganda Healthcare Federation. I don't know whether we have anybody from Uganda Healthcare Federation, our sub-awardee partner who was helping us with entry, convening, advocacy, negotiation with the private sector. Now, out there, though the activity, the project was not directly working with districts beyond Kampala, we are actually working through regional partners and regional referral hospitals to reach all the other districts. And the districts are here. And we talk to you virtually almost every day, every week. So we really appreciate the district teams as well as service delivery teams, not only at facility, but also community level. You are the ones who actually drive the work. For us, we only do the talking. A huge round of appreciation for these teams, the frontline teams. Partners. Later on, you'll see a list of partners that we've worked with, at least some of them, both development partners as well as implementing partners. As an activity, we have actually worked directly with some of the development partners, including UNICEF, WHO, including ERMA and their partners, etc. And then the various implementing partners, both USAID funded and non-USAID funded. And then finally, the consortium team, Makerere University School of Public Health, Uganda Healthcare Federation, Save the Children, Encompass, and some of our small sub-grantees at community level, White Ribbon Alliance, Youth Alive, and Child Foundation Uganda. Those were direct recipients from us at community level. So, now, how did we do this? We applied a systems and strategic partnerships approach, harnessing the power of information and data. And I will not talk more about this because I've already talked about how we are still utilizing data, how we've institutionalized this, and it is driving itself at all levels. Even at facility level within Kampala, monthly data reviews are happening, even without our presence because we have already pulled out. Private sector, having private sector facilities report through DHIS2. 1 quarter ago, we had moved from 500 private facilities reporting in DHIS2. Now, I think it's over 1,000. The number is over 1,000 with DHIS2 accounts. Making that happen. The big hospitals, private hospitals you see in Kampala have their own reporting systems internally. For them to agree to actually ensure that they add on DHIS2 or integrate so that the data can go directly to DHIS2 from their system, it's a hurdle. Approvals would have to be obtained from the proprietor in Nairobi, in India, and sometimes that would take 8 months. But we made that happen, and we do appreciate the flexibility. Human resource for health. We touched on all aspects of human resource for health, strengthening, working together with our counterparts at KCCA. Competences, that's a given, training and mentorship, but we use the information and evidence to actually lobby and advocate and engage our colleagues at KCCA to recruit medical officers and anesthetists to address the issue of referrals, emergency CTN sections at health center force. So at one point we put together a proof of concept for that. You could call it research or something. We recruited 6 medical officers, 4 anesthetic officers, deployed them, tracked, and looked at referrals going from Kisenyi, Komamboga, Kawala to Kawempe. Are they reducing? And we demonstrated that actually those unnecessary referrals went down. Then went back to KCCA. Hello, recruit these cadres. And they did recruit them. And we do appreciate the partnership with KCCA around this area. Preceptorships, and then of course community resources, very, very important. Now, when you talk of a community health structure in an urban area, one may think that it isn't there. They are there. They are community resources. They are VHTs. In places they are not there. Sometimes the LOC1 is the VHT, a lot of the times, and maybe his friends. Then there are volunteers in there. So we mapped. We went into communities and really mapped these resources, strengthened them, gave them skills and knowledge, equipped them, and then deployed them because they know those parishes and LOC1s and villages better than us. And you can't believe there is a lot of work there that needs to be done. The urban under-resourced communities and populations, I don't like calling them urban poor. No, they are not poor, they are under-resourced. They are out there yearning for these services. And through mapping and strengthening these community structures, we're able to reach them. Funding. Because of information, and we started with Kawempe National Referral Hospital, the team that is here, thank you, and we do appreciate for allowing us to dive into your data and actually show you what the hospital is dealing with or was dealing with at that time, and that continues to happen. And when that data reached the Ministry of Health, because the PS was part of the weekly, deep dive meetings, Kawempe Hospital was able to have their allocation for drugs and commodities increased 3 times. Just data. So the issue of chronic stockouts for everything started becoming less and less of a problem. We also worked with our colleagues at KCCA to do public finance management. At one point, we had a couple of could call them auditors, or you can call them that, who went in and helped with some of the backlogs that were existing and therefore blocking KCCA from receiving more funding from Gavi, UNICEF, and other donors. And so those taps were reopened, and KCCA started getting funds going to them because of those initiatives. I think JP talked about the corporate society for safe motherhood. He's the one who coined that word, corporate society for safe motherhood. So I remember we invited the corporate directors and MDs to Kawempe, and we did ward rounds with them. They reached the newborn care unit, and some of them cried. And then they started giving us things to work with. Now, that's mobilizing resources from the non-health private sector. And that is going on, still going on. It is driving itself right now. Yesterday, I had on radio Stanbic talking about their initiative to raise more funds without anybody pushing them to do this. So the space is fertile, not only for Kampala, but for the whole country. The space is fertile for leveraging funds from the non-health private sector to be able to move forward. I talked about community structures, so I will not talk about that again. Commodities. Now, this is a very, very difficult area. And over the past couple of months, I think over the past 3 years, we've had a handle at this within the KCCA area. I already talked about Kawempe, ordering, reporting, and management of stocks. We do monthly commodities data reviews and real-time corrective actions. And in the house, we have every actor within the city, be it IPs, all the IPs are in the room. National Medical Stores is in the room. JMS is in the room. And we look for solutions on a monthly basis after circulating dashboards showing what is happening around this area. And we've shifted positively. Routine service delivery processes speaks for itself. QI. When we started doing the weekly MPDSR meetings, the feedback from the districts, our midwives, was, you know, you keep on talking about QI. Why doesn't ministry come here and show us how to do QI? And people have been doing QI, but only in HIV and TB, but not in MCH. Now, at national level, we're able to put together, develop, disseminate the required tools to be able to advance the QI agenda for maternal, newborn, child health, as well as nutrition services. And we cascaded this to Kampala. QI collaboratives, Richard will be sharing some examples of successful QI collaboratives around MCH. The IDEA approach at community level, this uses a gender lens to actually do improvement at that level. This is a WIHA. WIHA is an American organization. This is a WIHA model. So we've been able to advance that within the city. Quick learning and adaptation using data. Host-led programming, I talked about that. How the government, Ministry of Health, as well as Kampala, the private sector owners, the medical bureaus that govern the faith-based facilities, are at the forefront of whatever we've been helping them to actually implement. Partnerships. This has brought in complementarity, and the partners are many within the city, and I are listed there. Some of them are development partners, whereas others are implementing partners. I talked about data, and Richard will talk about this later on in more details, so I won't be spending time here. But the point here is data driving everything. Very, very important. Now, your thing has disappeared again. Yep. coming. So, now this is the last slide, by the way. Apologies, JP, I've taken a lot of time. But you know the passion, huh? Yes. The passion. Yeah. So, my colleagues are going to share with us a summary of key outputs and achievements that we registered working together with the Ministry of Health and Office of the Prime Minister. They are going to outline. And some of those are some of the guidelines that are going to be launched later today and tomorrow. Then that Agnes will share that, so you'll call upon her. Richard, he will introduce himself. He will dive a little more into Kampala and show you some of these things that I've been talking about. But as we are doing these things and providing technical assistance, we are mindful of the fact that we need to harvest knowledge, new knowledge that may be emerging, so that we put it on paper and we share it with everybody. You know, what really works and how do you do it? Some of the areas on what works, we know because it is in the guidelines which the experts put together. And earlier, I didn't talk about NASMEC, but it was listed in my slides. NASMEC. JP, what does NASMEC mean? National Safe Motherhood Experts Committee. That term was also coined by JP. And we put together that. I don't know where, I think JP, you shouldn't have been a doctor, you should have been a literature student. So that's a structure that was informal at that time. And if there are any members of NASMEC in this room, they are there. Dr. Nonge, Professor Annette, can you stand up for recognition? And I will say why we are recognizing you, NASMEC. Yes, thank you. Way back in 2020, he coined that word. And we said, okay, we have brains in this country. How can we get these brains to get together and actually give us all these guidance, tools, strategies, frameworks, do them without us paying them? Don't feel bad. That we didn't say that we are not going to pay you, but that we knew. So these NASMEC members had task and finish teams. They still have. Anything that we feel needs to be done, can we update the cesarean section protocol? I'm giving you an example. I'm not a gynecologist. The team says, we are going to do it, give us 2 weeks, and they agree who is going to do what, who is going to review what, and they will do it. So these guidelines, protocols, training packages that Agnes is going to show on one slide have largely been done by NASMEC without us paying them. You can't imagine. This is a passionate group that has done wonders so far. And I wish I could be made a permanent member of NASMEC, even after retiring. I remember in 2020, we developed the PPH framework, the first one, during lockdown. Each one of us would work from their house. Right when they lifted the lockdown, we actually disseminated it. You remember? At Africana. PS launched it. That framework was done under the hardest of circumstances. And following that, many other frameworks have been done. And they continue to be done to guide the service provider at frontline level to be able to provide the service, save a life, give a life. So, appreciation. Now, some of the new knowledge, it may not be new knowledge, but knowledge collated, put in one place, is available in some of the legacy knowledge documents for their projects. And we've put those together. Richard has some QR codes. You can use your phone to look at it. But we are going to upload them on the ministry portal. There are still about 3 or 4 which are being worked on by the technical people, and they will all be available on the portal, which is written there. These are the new guidelines that we've talked about, whether they are maternal, newborn, child health, immunization, nutrition, family planning, etc. I already uploaded on that portal. As soon as the launch happens, the document is uploaded so that everybody in the country can actually access them without need for looking for a hard copy in somebody's office. So that portal, that's yours. That portal is a ministry portal, and we've helped the Department of Health Information at the ministry to revamp it for easy access. It is now available, and we keep on uploading the documents there, in addition to many other documents the ministry owns. So please, ladies and gentlemen, utilize that. JP, apologies. I took a long time, but I wanted to sort of paint a bit of history so that people appreciate us, and also gain the enthusiasm to go to that portal and see a lot of these frameworks that we are talking about. Thank you very much for listening. Have a good afternoon.
A second round of applause, ladies and gentlemen, for Nathan. And the main reason why we've let Nathan share this story, because there is no other better person who can share it than Nathan himself. He has been the kitchen at the foundation of setting up MCHN and all the other aspects that have brought the entire team together. It's been teamwork. And why we are here is because we've created a dent in maternal and perinatal mortality in this country as a team. Our next presenter. Now, Nathan, you will allow me to restrict the time for the other presenters, because I see you've given the entire introduction. So my next presenter, Ms. Agnes Namagembe, Senior Technical Advisor for Reproductive, Maternal, Newborn, Child and Adolescent Health for FHI 360. Please, if you can share with us your presentation on collaborating to implement RAMCA strategies and guidelines for high-impact interventions, national and subnational level. How many minutes? 10? 15? That would be great. All right.
Did we talk about gender? There should be some gender considerations. Nevertheless, good afternoon, colleagues. I want to continue riding on the already set protocols to share an opportunity of USAID MCHN's experience, successes, and achievements in collaborating with other stakeholders in rolling out RMNCH and nutrition strategies that are very impactful at national and subnational level. Sorry. So just to pick on from where Dr. Nathan has stopped, at the start of the project in 2020, the activity or the project conducted a joint inventory for existing as well as required strategies. And this was done along with Ministry of Health, working closely with its technical working groups, subcommittees, development as well as implementing partners. Not forgetting the Office of the Prime Minister through its multi-sectoral nutrition secretariat, development and implementing partners. Following this, there was joint designing, implementation, and tracking of a roadmap for the development, updating, review, as well as approval of the prioritized documents. Emphasis was also put on dissemination of the completed documents, both at national and subnational levels, as it had been identified as a weak link previously. We know that a number of documents have been on the shelf for a long time, and they haven't been trickling down to the lower health facilities. Last but not least, there was emphasis on the need to ensure that the completed documents can be rolled out in non-conventional ways, including training, mentorships, as well as uploading on the various platforms available. Last but not least, the roadmap stressed the need to strengthen the functionality of the aligned technical working groups and subcommittees with a focus on use of and institutionalizing use of tools to standardize business. We brought in an idea of having a standard agenda for all the technical working groups, and this included review of action points for accountability, having data analytics to drive agendas, as well as one unique presentation to aid learning for the people who have convened. And we see that this has worked well, and that is something that we are proud to say we've institutionalized. All the technical working groups are able to use data and reflect on their progress. Last but not least, on this particular slide, there was need or an agreement to utilize online platforms for communities of practice to aid learning, sharing of best practices, as well as dissemination of strategies that would have been completed. So on this slide, we point out the process and partnerships we leveraged to roll out the prioritized strategies. USAID MCHN activity, under the leadership of the Ministry of Health and the Office of the Prime Minister, provided technical and logistical support for updating, reviewing, adapting guidelines into the national context. Just to break this down, we were able to provide, to work with the Ministry of Health to convene writing workshops, as well as convene stakeholders to put or adapt global guidance to national context. Support was also provided for pre-testing these guidelines, as well as having them validated by the stakeholders in place through convening stakeholder meetings. Not forgetting support for fast-tracking approvals, as well as copy editing into usable forms, user-friendly forms. I also want to stress the need that, unlike previously, a lot of emphasis and support was provided to these Government of Ugandan structures to ensure that dissemination was conducted at national level, but also subnational level, using virtual platforms, as Nathan has highlighted, physical engagement, as well as enrolling or sharing these documents on the Ministry of Health portal, This would not have been possible without collaborations or selected strategic partnerships with other actors at national level. I want to, in a special way, appreciate the work we've done with the Ministry of Health, the OPM structures, our UN agencies, UNICEF, WHO, UNFPA, the World Bank. We worked very closely with them to develop the sharpened plan, USAID implementing mechanisms at above site, as well as other implementing partners, World Vision, Save the Children, to mention but a few. At regional level, we also worked very closely with regional IPs, both USAID and non-USAID, regional referral hospitals, as well as the 11 LMNSs, as been highlighted in the previous presentation. So, as a result of our collaboration, we note that over the 5 years, we've had 29 strategies developed. I want to pause at this point and clarify that for this presentation, the term strategies refers to policies, guidelines, tools, as well as frameworks to guide implementation, not necessarily, so it's a little bit bigger. So of those 29, 24 have been rolled out, and 4 of these are maternal health related, 2 are newborn, 6 speak to child health, 7 are nutrition related, and 7 are cross-cutting. That includes the sharpened plan, the quality of care guidelines, among others. Is it working? I thought I was whispering. So this slide I wanted to highlight that this is work in progress. You can't say you've completed updating guidelines. Even tomorrow, I think the first presenter from UNICEF highlighted that they're going to release guidelines about newborn care. So this is ongoing work, and we note that at this point in time, we have 5 guidelines that are pending approval, including guidance to implement the LMNS strategy, as well as the Respectful Maternity Implementation Framework. But I also note, and I want to rally all the stakeholders in the space to support Ministry of Health continuously update guidance based on global releases. The project has also leveraged the LMNS and MPDSR platforms to ensure that there is ongoing sharing of learnings, accountability, referrals, improved referrals, and real-time consultations. And I won't spend a lot of time on that because Dr. Nathan did a good job. This is an example of a partnership or partnerships that we demonstrated working in the Ministry of Health to partner with the subnational structures to cascade the updated ETAT Plus guidelines as well as IMNCI at district and facility levels. So we started off with conducting national trainings, and this was in collaboration with WHO, UNICEF, and the Uganda Pediatrics Association, where master trainers were trained, and these in turn conducted regional trainings in those regions listed there. And this was in collaboration with a number of partners. The list is long, so I'll not go over it. And these partners, these regional trainers, together with their regional IPs in their different catchment areas, then rolled out to the district and facility level. And as Nathan highlighted, the scope of the project was restricted to catalyzing linkages between the national level and subnational structure, and not necessarily duplicating efforts of the regional level structures like the regional referral hospitals. As I conclude, overall, the contribution of the collaborations to roll out the various strategies has improved maternal and child health outcomes in the country. And as highlighted yesterday from the MPDSR report and the recently released annual health sector report, we note that there's been a dent in mortality over the 5 years, but also a reduction in the negative outcomes of nutrition, including stunting and wasting amongst our children in the country. And this has been attributed to improved provider competencies and adherence to standards that has contributed to enhanced quality of the services that are being provided. I want to thank you all for listening, and over to you, JP.
A second round of applause to Agnes. And I really want to thank her for serving us some 5 minutes. That was very powerful, Agnes. Thank you very much indeed. And ladies and gentlemen, the main reason why we come every year for the National Safe Motherhood Conference is to share these best practices, to see what the Kampala Metropolitan Local Maternity and Neonatal System can learn from Chigezi Local Maternity and Neonatal System, can learn from Karamoja. The cross-pollination of ideas is what is going to move us from one point to another point. And really for me, when we hear these phenomenal stories of the progress that we've made in a very short time, combining our efforts as a team, it's what we have to continuously do. And that's how we are going to end preventable maternal and perinatal deaths in this powerful country of ours. Without any further ado, allow me to go to our next speaker. And that is my brother Richard, who I know is also going to save me some 5 minutes. And he's going to share with us the Kampala data-driven approach to enhancing urban rum care and nutrition services. My brother. And by the way, to let you know, he needs a very hand clap, because this man here He's also the chair for finance for the National Safe Motherhood Conference 2024. So that round of applause is not good enough. Thank you very much indeed. And we look forward to hearing from you, my brother.
Thank you, JP. I know people have been eager to see who Kajimo Richard is. Many have not had a nice experience, but I'm glad you're here finally at the conference. So I'll be speaking to the work we've done with the KCCA, Kampala Capital City Authority, as well as the other public facilities and private facilities within Kampala, including Kawempe National Referral and the private sector. Dr. Nathan has done a good job, so I'll just run over the data because he said we've been using a data-driven approach. So what does the data look like, and what are some of the change packages or the game changers that have been employed to see the results that we are going to be seeing today? So a little bit of the dynamics on Kampala. Kampala is quite different from many of the cities we have across the country. The populations are different during the day and the night. We have half the people sleeping in Kampala. Most of you come here to work. So we have to plan for the day, guys, and also plan for the night population. It's very, very tricky and difficult. It's also surprising that the unemployment rate is 26.3%. Most of us want to come to Kampala for jobs, but actually the unemployment rate is very high in the city. And when Dr. Nathan talked about the under-resourced people, these are the people we have to support to make sure that they get quality health services. We have about 339 health facilities, and only 1.2% are public facilities. Majority, 96%, are private for profit, meaning that the people within the city have actually to pay for this service in one way or another, factoring in the unemployment rates. But then 60% of the population is slum dwellers. And this is where we focused most, to make sure that the facilities that are within the slum communities are able to provide an affordable quality care service for women and children. So I'll leave out the rest because I think Nathan has spoken to that. I'll start with antenatal care attendance. Within the city, we've seen tremendous improvements in antenatal care attendance, especially for the fourth visits, rising from 25% in 2019-2020 to 73% in the current financial year. Much of the efforts have been around mobilizing these communities, and I know that our colleagues, the Social Behavior Change Activity, SBCA, have been very helpful in designing materials, a family health care campaign that has worked in Kampala to ensure that women are able to understand why they need to attend antenatal early, but also complete all the required visits. But also we've done a lot of work in using QI, using the IDEA approach that Nathan talked about, as well as the high-risk collaborative to make sure that we mobilize women to attend antenatal, identify high-risk women, and link them into care and keep them within care as well. But amidst that, we see a low attendance in the first ANC within the first trimester, and the complexities are because Kampala is a transient population. Okay? People are coming in, people are going out. Many times when women get pregnant and are about to deliver, they want to go and deliver with their grandmothers in the village. So maybe they do not actually attend antenatal here or deliver here. We have mixed communities, different cultures, different tribes, different countries within the city, refugee populations. Reaching them with one single message is not possible. You have to tailor messages for different communities. You have to understand their cultural perspectives, and address all the myths and misconceptions. It's been very complex, but our SBC colleagues are helping us there. In terms of newborn resuscitation, we've made also tremendous improvements. We've seen more babies being born struggling to breathe, but then resuscitated successfully, rising from 85% to 96% within the current financial year. But also generally, we are seeing a decline in the number of babies who are born with asphyxia. And I want to say that efforts have not just been us, but there's been a lot of trainings, mentorships, but then the collaborations with UNICEF, supporting Save the Children, I think had some work around resuscitation. Dr. Victoria Nachibuka is doing work around resuscitation within the city. So we work together to see that we're able to save more babies within the city. CQI, this is just one of the examples of quality improvement, the high-risk collaborative. I think Kampala has done extremely, extremely well in the high-risk collaborative, and we thank KCCA for this effort. So we have been working in 24 facilities, and we've seen women who are able to receive a complete risk assessment at ANC rise from about 50%, are now being sustained at 100% in all these facilities, all of them being assessed for a high risk. Thank you very much, our Kampala teams. Now, the women that are identified with a high risk are supported to have an individualized birth preparedness plan. And that has come from 33% to now 94% within the supported facilities. Health workers spending time to work with these women to ensure that they are prepared for their birth, the labor and delivery, and thereafter the postnatal period. And out of that, we've seen the outcomes improve within the city. Within the cohort of the women we've worked with, the pregnant women we've worked with between January 2023 to March 2024, 99% walked out of the facility alive and with a live baby. We had, I think, about just 34 maternal deaths, no, 2 maternal deaths and about 34 perinatal deaths within that period in the facilities that are implementing this collaborative. I'll quickly run to MPDSR, and a lot has been said. We launched the report yesterday, but what is the story within the city? The perinatal death reviews were the lowest in this country, in Kampala, at 38%. As we exit and KCCA takes over and sustains this and Kawempe National Referral, they are able to review more than 50% of their deaths and understand the issues and set up action plans to address these issues. So we have to appreciate the teams in Kampala who sit every day. Kawempe sits almost every day because they have about 70 perinatal deaths, okay, on a weekly basis, and they have to review half of those to understand why these babies are dying. Maternal death reviews have also risen from 87% to being sustained well above 100%. The greater than 100% is because of backlogs. What have been some of the results, the actions that have taken place as they review and develop action points? We've seen improvements in health workforce. Nathan has talked about the proof of concept that we did with KCCA, and now they've received a new approved structure, staffing norms for their facilities, and they're working on recruiting more health workers within the public health facilities in the city to ensure that there's 24-hour CMOC functionality in Chisenyi and Kawala. Before, some of these facilities would never do scissors at night. They would refer them to Kawempe. Now we know that Kawala, Kisenyi are doing cesarean section day and night because of the investments in health workforce. The hub and spoke model. I think the hub and spoke model that's now being rolled out in the country has been an exemplar from Kampala Capital City Authority. The city decided to use a distribution model. If you're familiar with Movit, the Vaseline, okay? So they have, this is what the director KCCA would say if he was here. They picked that model where there's a warehouse and then you have distribution trucks, okay, that are stationed within different regions who distribute to wholesalers and then distribute to retailers. So they developed something similar for their facilities and got hub facilities, which are CMOC facilities, to be able to support the BMOC facilities that are within their catchment in terms of top-down referral support, mentorships, and supervision. And through that, we've been able to reach private and public facilities with trainings on helping mothers survive, helping babies survive, and many other frameworks have been rolled out through that. Service delivery, KCCA has been able to procure 7 additional ambulances. They have a referral, the cadet system, which is the Kampala Emergency Dispatch and Call Center, and they're able to support referrals in real time. As soon as their facilities communicate, they dispatch ambulances, track those referrals, and ensure that they arrive in time and these women are saved in time. There is also now a 24-hour coverage for CMOC functionality, as I've said. The referral protocols have been put in place and shared across. Each facility has a number, a contact person of who they should call before they refer, to seek guidance, to make sure that they prepare for this woman who is coming and attend to these emergencies in time. Health financing, Nathan talked about this. We've worked with a corporate society within Kampala. MTN organized a marathon run for babies and we're able to do an oxygen plant for Chisenyi. We've seen Stanbic Bank giving gift hampers, supporting newborn care within Kawempe, as well as other facilities. This also has been talked about, ensuring that we have the essential medicines and supplies. Now, engaging the private sector has been very, very instrumental to this work. We were able to work with KCC and map all the TBAs. It's surprising that Kampala also has traditional birth attendants. Over 49 of those, okay? Now, KCCA has a real-time map knowing where these are because we have the geolocations, okay? And they are being followed up to make sure that they stick to their role of referral, okay? And most of these were causing a lot of issues. So they were visited, they were assessed, they were supported to make sure that they do not retain women there. KCC has been issuing management letters to private facilities that do not perform well or lose a baby or a mother, especially where they have gaps within their health system building blocks. And some of these have even been closed. Some have been supported, mentored, trained, supported to have protocols and guidelines, and they are now doing much better. And because of that, KCC has won a lot of awards, and we should clap for them. Many of their facilities have been recognized in different ways. I've spoken to this. Cesarean sections have gone up within the KCCA facilities in Kampala, and thus the referrals have reduced. We've seen a decline in the institutional perinatal mortality rate. The maternal mortality rate is still staggering. But I know that teams in Kawempe, where most of the women die, are working so hard. But most of these are referrals that come from outside, actually, Kampala. And they struggle with this and do their best. Child health, we've seen improvements in vaccinations for the childhood vaccines, as well as ensuring that all our children are fully immunized by 1 year within the city, coming from 31% to 80%. We've done some work around profiling zero-dose children, making sure we know where they are, what are the reasons why they are missing some doses, and then design strategies to make sure that they are reached, and we address some of the gaps there. Family planning, especially postpartum family planning, has come from 11% within the city to 60%. Now women are able to have a family planning method of choice because of the efforts of the health workers within the city. We've not forgotten about gender, the youth, and making sure everyone is taken care of. We've done some work with our partners within the city to ensure that we reduce all forms of GBV, gender-based violence, and ensure that those that are victims receive services appropriately. Nutrition has also improved. I think I've seen Madam Samali, the Assistant Commissioner for Nutrition, within the Ministry of Health. We've seen nutrition assessment within the city come from 5% to over 70% in all the public and private facilities. And this is, more work has been done in the private sector. And therefore, they're able to identify children who are malnourished and link them into care. And we've seen a reduction in malnourished cases within the city. We've done community work, reached children below 2 years with vitamin A supplementation, deworming, as this slide speaks to that. I'm trying to run through because of time. And finally, the reporting has also improved. And Nathan spoke to this. You see where we started from, reporting on time from 19% to now 75%, making sure that within 2 weeks, by the end of the month, our facilities have reported into DHIs to their data. Thank you very much.
Yes, and I want to thank my brother for saving me some 2 minutes. And it's very important for us to appreciate that for KCCA to do well, districts like Mukono, DHO Mukono, I saw you somewhere, DHO Mukono, where are you? Yeah, excellent, yes, DHO Mukono. When you do well, KCCA does well. I saw a DHO Wakiso. Wakiso? Excellent. When you do well, KCCA also does well. Impiji, is Impiji in the room? So the neighboring districts, when you do well, also the indicators of KCCA significantly improve. So that is what it means, that we have to continue to work as a very, very solid team. That was a very powerful presentation on data-driven approaches. And the message here, as we go back, and the PS said, as we open the 4th chapter of safe motherhood in this country, we must get back and embrace data. Capturing data, understanding data, appreciating the data, and utilizing the data to improve our practices back in our respective local maternity and neonatal systems. Colleagues, allow me invite our next presenter, who will share with us some of the lessons and takeaways on KCCA's behalf, and that will be none other than Dr. Chris Owundo, the Division Medical Officer for Nakawa KCCA. Dr. Chris, and I know he's going to save me some 3 minutes as well. Thank you. We're really doing well in terms of time. Dr. Chris.
Thank you. Good afternoon, ladies and gentlemen. I bring you greetings from KCCA, from my boss, who is unable to be with us here due to some of the issues some of you are aware of. And I will add my voice to the protocol which was recognized. I am here basically to agree with what the team has presented. All those were takeaways from the period we have been with FHI. And we're praying that they don't go, but I think this is inevitable. We still count on those who are coming on board to support us. Can I? Okay. Yes. So as I take some, oh, this one. Oh, right. Yeah, I was also taking some lessons from the team. Yeah, what are the takeaways? We need to appreciate that the government of Uganda stewardship at all levels is essential for fostering local ownership, responsiveness, and sustainability As you can see, we had a disengagement. I think it's the other side. In one of the photos, we had the Minister of Health and the KCC officials and Minister for Kampala. And this was during the partners' engagement for maternal child health symposium. And this was basically reaffirming commitments to reducing maternal and newborn mortalities in the facilities of Kampala. So as the leaders came on board, it was an energizing moment for all the stakeholders involved in this to see that the commitment from the top is key. What we need to appreciate is that stewardship at the other levels, like for the case of Kampala, of course, you are looking at divisions, which operationally are districts. And we also have levels below districts where we have key stakeholders that are critical. And the basis for that is the fact that when you are talking about Kampala, this is where you are finding that 99% of the facilities we have are private facilities, privately owned. And this number has been expanding. We had an opportunity in 2018 to do a mapping. At that time, we were able to identify 1,500 facilities. But last year, with support from FHI, the geo mapping, which was eventually undertaken, we were able to identify slightly above 2,000 facilities. You can see that the private facilities have been expanding, the public are the same. And when you talk about, like the previous speaker has been able to demonstrate that the numbers have been increasing. If you are looking at, say, antenatal care, OPD attendance, and other parameters, the numbers have been increasing, and you will realize that the increment may not be that we are attracting more people in our public facility, because they are bursting. But it is largely because we are bringing on board many private facilities that were not reporting to do the reporting, but also improving the qualities in there. And as such, you find that our parameters get better. So the engagement of leaders at all levels is that approach which we have relied on to get the proprietors in the private sector on board. We also had engagement of the business community, who are critical to provide resources that normally the government may not be available to the government disposal for improvement of services. And here we have seen Stanbic Bank, for example, make a significant investment at some of our public facilities. We know we have now the oxygen plant at Kisenyi. We recently, for example, had the staff of Stanbic Bank making a donation for antenatal care equipment to Kiswa Health Center. And there are so many other examples. So this mobilization platform is a very good opportunity that we shall continue riding on to make sure that we are able to improve the quality of services that we provide. This has also been well elaborated by the previous speakers, the issue of data-driven stakeholder engagement and advocacy, which stimulates local investment in health. The decisions we make are data-driven. And it is from this data that we realize that one of the key delays leading to maternal and perinatal deaths was the challenge of accessing ambulance services. And that enabled us to make a case to have KCCA prioritize the procurement of these ambulances, which are helping us. And you know, the way we are managing these ambulances is also a takeaway approach for others to pick. You know, quite often, personally, I had the opportunity to have worked in a local government. And you will find that one big challenge is the effective use of these ambulances, whether they are abused or not, or if they are really supporting the purpose for which they are provided. Now, for us, we have an EOC center, which is a centralized mechanism of managing these ambulances that when the need arises, the call center is raised, they do a quick triage, and they're able to dispatch an ambulance. And for that, we are confident that all the ambulances are doing work they are meant for. We were also, okay, I had talked about the oxygen plant. One of the biggest reasons for referrals from Kisenyi to Kawempe was the challenge of oxygen in the operating center, in the operating theater. And this was timely when we were able to get this investment in order to address that challenge. The other takeaway is the fact that the strategic partnership approaches enhance synergies and promote mutual accountability, driving sustainable impact. So here we can see the key partners that have been in this journey on the newborn partners for Kampala. You said MCA chain activity, of course, we really appreciate, and we are very grateful. We also have the SWAP, that is saving women, and saving women and preterm babies project. This is supported by Save the Children. We also have the resuscitation, infection prevention and breastfeeding, the RIB team, which is funded by Elima and Dr. Nachibuk. I don't know if she's within here from Zambia Hospital. She's the brain behind this, and this has been very timely. And of course, we also have UNICEF, which is there and is making significant contributions in enabling us undertake a number of interventions within the city. And those are the areas of complementarity and synergies which we have been working on, including trainings and mentorships. And maybe just to emphasize something on mentorships. You know, at programming level, there is a tendency to allocate resources to specific facilities. Like you had that in the design, MCHN was targeting 23 facilities. And quite often, these are high-volume facilities, and which are largely public or PNFP facilities. We had a question. For example, we want to undertake mentorship. And one of the listed facilities is Zambia Hospital, Naguru Hospital. So the question was, whom are you going to mentor and who is the mentor? Because the people you would want to mentor are the one in these hospitals. And yet, the reasons they're having maternal mortalities and newborn mortalities are largely from the data we had, late referrals coming in from specific, well-mapped facilities around there. So as KCCA, and that's why we appreciate the flexibility of the team from FHI, we were able to agree that let's do the mentorship. Let these hubs now, the hub model, let these 23 facilities be designated the hubs so that they can mentor the facilities that often refer to them. And of course, using staff from those same facility was a much better approach because they strengthen, first of all, establish rapport with the providers the other end, but also in the process strengthening linkages and referral mechanisms so that if there is a challenge, somebody can pick a call and reach out to the senior person at the other end before even referral is effected. So so many other areas, HMIS, strengthening HMIS reporting. As of today, about half of the facility are enrolled in the DHIS2 system. We would wish to have 100% facilities in Kampala enrolled. Of course, if that happened, our data will skyrocket. We shall be able to demonstrate the contribution of all other persons, other Ugandans who have invested in provision of health care services in the private sector, and we shall be able to plan it better. This is not possible without the partnerships, because we do not have the human resource to go out there to mentor each of these new private facilities and follow them up on weekly for the weekly surveillance report, but also monthly and quarterly for the rest of the other reports. We have also, this collaboration was able to support quality improvement initiative, supply chain management, newborn equipment, stimulation labs, human resource for health enhancement, and nutrition. We can confirm that up to 9% reduction in the institutional perinatal mortality rate has been documented during over this 3-year period from 2020 to date. So you can see that we have saved significant lives as a result of this collaboration. And finally, this has also been well elaborated. Nathan made a clear description on how anchoring technical assistance at both national and subnational level streamline system-wide improvement efforts and foster local ownership. We have seen that guidelines that are coming from Ministry of Health, as they update them and review them, they are informed by the data coming in from the implementing, at the implementation level, at facilities. And we are very grateful for Ministry of Health to continue leading on that front. We have also seen how the regional mechanism is working. Yes, KCCA had the G2G as well. Unfortunately, we lost it early this year. But we have Nagulu Hospital, G2G. So working with the Nagulu Hospital and currently Reach Out to Mbuya, we are still strengthening some of this initiative which we started on. And at district level, in our case, like I said, we look at divisions for that purpose. There is a lot of work going on there, and all this eventually feed back into what the Ministry of Health comes up with. Chair, I want to thank you, and want to appreciate all partners that have supported KCCA in strengthening maternal and child health response in the city. Thank you very much.
Thank you. And I'll request you, Dr. Chris, just to take a seat at the frontier so that we can get some questions from the audience. We'll take only 4 questions. But let me also invite the other speakers, Dr. Nathan, Ms. Agnes. And as they come, can we have, please, the visual of the MPDSR story as the panelists come here to take some 2 questions. And let's see that MPDSR story. And if you have a hot question that you really think that should be responded to, not in the 5th NSMC, but in the 4th NSMC, this is the time. And the male champion, male involvement champion has a question, and then we have another question there, so 2 from this side, and then we shall have 1 question over there. Let's have the MPDSR story, please.
Maternal and perinatal death surveillance and response is a quality improvement intervention. There's a global guidance that every maternal death that happens, that occurs at different levels of care should be notified, should be reviewed, and actions should be identified. An action plan should be made to prevent the next death.
So the MCHN activity has been collaborating with the Ministry of Health and other stakeholders to improve the maternal and perinatal death surveillance and response system. Right from the start, we collaborated with our Ministry of Health counterparts to ensure that they are able to meet and review maternal and perinatal deaths. So they were initiated what they call the community of practice. The National Community of Practice is a group of stakeholders who come together every week on a Thursday to review and account for the mothers and the newborns who died in the previous week.
USAID MCHN stood with us. We needed a dedicated team of personnel that would deliberately focus on picking the analytics, analyzing the analytics, following up with the districts. We have over 140 districts. We enhanced our MPDSR by doing a deep dive into cases of maternal death that happen specifically at lower level health facilities. So these virtual platforms are also referral platforms. If you're sending a mother to another level of care, please, I'm sending you a mother, this is what I've done, and expect this mother in. I'm stuck here, I need blood. So we are using these platforms, virtual platforms. So our MPDSR of Uganda is both a learning and accountability. That's the uniqueness. For example, if there is a problem with equipment, problem with blood fridges, problem with infrastructure of a theater, you'll need funding. So being able to share some of these annual reports, MPDSR reports, with members of parliament, with the Speaker of Parliament, so that we could use them as advocacy tools to guide resource mobilization.
To make sure that when mothers are referred and they need blood, blood is readily available. For all blood groups, from group O, group A, group AB, and group B, blood is always available. We have also introduced a distribution system whereby our lab staff can take blood whenever they go on their supervision trips. So they go to the healthcare facilities, they help them to account for blood, they help them to manage their needs so they can have blood as and when it is needed. And even then, we have also introduced Zoom meetings, weekly Zoom meetings, whereby we share what has happened, the maternal deaths, how we can improve. And this will have really improved blood stock levels in the healthcare facilities to avert maternal deaths in those centers.
We were seeing minimal implementation of the recommendations that were coming from the MPDSR conversations. So much of the conversations were remaining national. We weren't having regional involvement. Majority of the regions will only point at the Ministry of Health. We have this problem, we don't have sundries. Ministry of Health, you're supposed to help us do that. Absenteeism issues, Ministry of Health, you're supposed to address that. These maternal deaths are happening in our region, Ministry of Health, you're not doing your job. So everything was coming to Ministry of Health. And so that's how the local maternity and neonatal systems came into being.
There are those very solid impacts that we have seen the LMNSs have done. Are our national and regional referral hospitals taking responsibility to drive the regional transformation agenda? For us, we are very happy when we see Kawempe National Referral Hospital now on top of transforming maternal and newborn service delivery in Kampala Metropolitan, because it's a national referral hospital, and that is one of the responsibilities that it's supposed to do. We've been able to also bring on board the private sector. The private sector is now fully on board. Previously, teachings will only happen, mentorships will only happen in the public sector. Why? The private sector, no one would really pay much attention. But now, because we've also been able to embrace technology, that much of the teaching happens virtually.
The KLNMS has done a great job, because if I was delivering 120 mothers a day in 2019, 2018, and currently I'm delivering 60 to 80 mothers a day, it means that something has been done. I'm sure when you walk around, you're also happier.
We are able to easily, in a minute, get a communication from the center to all the 15 regions of this country in 1 minute. And we are sure that communication will have reached. Why? Because of the local maternity and neonatal systems. So there is proper alignment of partner support. There is proper alignment of the vision for the frontline healthcare workers. Now they understand where we want to go. For us to reduce maternal and perinatal mortality, maternal mortality reducing from 336 per 100,000 live births in 2016 to 189 per 100,000 live births 2022, and perinatal from 27 to 22 per 1,000 live births. It's an awful lot of efforts that have been gone in. And in no doubt, what we've done in MPDSR, what we've done in the local maternity and neonatal systems have made a very significant contribution.
In the last 5 years, we had a 44% reduction in maternal mortality.
There's been increased government participation, especially the Ministry of Health senior leadership, engaging with the data and interrogating the facilities on what were some of the avoidable things that they should have handled before these women came into the facility, encouraging NMS to meet their orders. They've also been improvements around blood supply, okay? Working with the Uganda blood transfusion services to ensure that blood is available in the facilities and is moved quickly to where it's needed. We've seen the teams engage more with data. I think that's been the biggest win, okay? People being able to look at the data and make timely decisions that are data-driven on how they can reduce maternal and perinatal deaths. So our recommendation is that the Ministry of Health takes this to scale to ensure that regions, through the local maternity and neonatal systems, are able to work with the data that is reported in our national health information systems and use that data to target their interventions on what they need to do best and earliest to save women and children.
Very, very powerful. LMNS coordinators in this room, you could just stand up for recognition. The LMNS coordinators. I think they are somewhere, yes, the LMNS coordinators, those are very, very magical men and women who are driving transformation in the regions. And a round of applause to the resources that enabled us put this story together, to FHI 360, a USAID MCHN activity. Thank you. Now, let's get the questions.
Yes, sir.
Male involvement champion.
Male involvement, definitely. And we are very happy that the Male Involvement Technical Working Group sits in the Ministry of Health. And my co-chair, Dr. Mugahi, is one of our strongest champions for engaging men and boys. And I want to just tell the team that actually male involvement was actually actually sits in the reproductive health. That's where it started from. And Kampala, talking to our Kampala champions, is that we trained male involvement champions in 5 divisions of Kampala City. Dr. Wundo knows us very well. And just to say that we trained father mentors, by the way. The Ministry of Health developed a male involvement training, together with WHO, developed male involvement training manuals and reproductive health was a key topic in this training manual. So just to put forward to the panel that actually you have champions who were trained in using our documents, our training manuals, and I just had hoped to hear something small from one of the speakers on the issue of engaging father mentors, the issue of engaging men, and my question, I think, let me get to my question to all of them. What have you done in that area, knowing very well that for safe motherhood, you need to have positive fatherhood? Thank you.
Excellent. Let's get the second. What was the second hand? Let's get my sister here, Juliana. Oh, yes. I'll really take strictly 4 questions. But I can't go without a question from our very senior colleague, Dr. Dan. Yeah.
Thanks very much to all the presenters. 2 quick ones. The first one is on TBAs. We heard yesterday the TBAs are there, the TBAs were stopped, and we're hearing stories about the TBAs. There's also a disturbing video about the TBAs. I'm hoping by tomorrow we can come up with a resolution on what we want to do with TBAs. I'm aware WHO has put standards on what we can do to give a role of redefining the role of the TBAs. Last 2 weeks ago, we are launching the health promotion, and you could see that we're talking about VHTs, we're talking about CHUs, yet the TBAs are there. You even have a referral hospital for TBAs. Quite disturbing. Is there something that we can make as a resolution so that next year we come here with a different stories about the TBAs? Secondly, it's about KCCA. Thanks very much for what you've shared with us, good initiatives. I want to ask the sustainability of your program because it looks like there are other agencies attached. My assumption was the city was able to do that. And also as the CCA, I wanted to know how you are managing, because when you looked at the indicators, MPDSR yesterday, and even what the doctor presented yesterday, we are not doing well as Kampala on the indicators, on the referrals. What different thing do you want us to see in the subsequent years so that we can see that we are making a difference in the urban? Because urban poverty hits us and we usually forget because we focus on the rural community. Thank you.
Dr. Dan. Dr. Dan Morocco, right over there.
I don't really cross the bridge.
Yeah, we can just go to the question.
Yeah, thank you very much. I congratulate you, Dr. Nathan, and your team for a successful implementation of the activity. There are some things which are cryptic that usually we face as implementers. We'd like to learn from you and your team how you navigated the various challenges and what you learned from that and what you advise other implementers. The second one is that in every presentation you made, including yours, there was a tinge of sustainability in basically everything that you did. What advice would you give the Ministry of Health, for example, and IPs here to build sustainability in everything that they do? And lastly, brother from KCCA, what proportion, if you can, just an estimate of all these interventions you think you'll be able to carry forward in case there was no further financing for them? And also, if you can comment on how you manage staff absenteeism in the city, that would be very helpful for us to know. Thank you.
Now, that one question has like 5 of them. But just hold a minute because I want to assess. This is a very powerful conversation. My brother Kamara Daniel, one of very excellent young nutritionists, will make a comment. Oh my Jesus. Okay, let's get Kamara.
Thank you
and then
so
we'll
much.
see how to handle this.
Thank you so much, Dr. JP. Now, my question goes to Dr. Kajimo. I am very excited for the nutrition indicators that you moved from 5% to 70%. That was extremely excellent. But now, just like in the urban, semi-urban settings, we have now increased the obesity rates. What are you going to do to prevent that? And also, the vicious cycle of malnutrition in these mothers who are attending antenatal. How are we going to bring out the strategies of ensuring the nutrition preconception care to come out clearly and have these mothers be attended to, or they prepare 3 months prior to getting pregnant? So that will break down the vicious cycle of malnutrition.
Excellent.
Thank you.
Now, can we jointly agree that you are going to borrow me some minutes of your lunch time? And the reason is that we stole some time from their session for break, isn't it? And I'm very happy that we have all agreed to that. Now, let's first respond to those quickly, yes? And then we shall take another round of questions. It's a very interesting conversation. And so for me, it's important that we really ensure the interaction is very powerful. Now, let's see, those who are going in the second round, I can't miss the Kampala Metropolitan LMNS coordinator. And then my sister right over here, that's 2. The Acholi LMNS coordinator, yes. And then my sister right over there, and we shall close. We shall close the section, the questions, yes. Let's respond, please.
Thank you, Chair, and thank you for the questions.
And we can just make it brief, to the point.
Yes, very good. I'll respond to a few of them. The question on male involvement, I think this has been with us and is still with us. And we have some initiatives that we've been undertaking. And for example, I want to answer this together with the question on TBS. So we identified the TBS and brought them on board as Mama Ambassadors. Why Mama Ambassadors? Is that we were incentivizing a TBA who helps a mother as early as possible in pregnancy, because these mothers don't only visit them during labor, they even go for antenatal care to this TBS. So a TBA who links up a mother to a specific facility, which we identified as a hub, would be motivated. That would mean that we are not kicking them out of business, but we were bringing them closer and having the mother at least undergo assessment by a trained provider. And in the process, risks can be documented early enough and proper management plan provided. In the same vein, using the same approach, we encouraged their partners, the male partners, to come on board along that Mama Ambassador approach. Well, this of course, gives us better results, as we could exemplify better later. Now, there is the other question I need to move to. Okay, the question on KCCA has done much, and yet we could be having other partners. Of course, KCCA works with and through partnerships. You cannot deliver the services in Kampala if we go solo as government. First of all, like I had highlighted, when you talk about human resource for Kampala, we are just a drop in an ocean. If you look at the population and available human resources, we are very, very few. And related to this is the question of absenteeism. If you look at the staffing norms for Health Center 3, Health Center 4, remember that our KCCLS facilities are Health Center 4s and 3s, and then 2 Health Center 2s. The staffing norm cannot work for Sekisenyi that sees up to 1,000 clients on a daily basis. So we have been engaging Ministry of Public Service and Ministry of Health to revise the staffing structures for KCCA, which they did partially, but the engagement is still on. And you will realize that the staff that we have are largely on a 12-hour shift. Now, that also presents a challenge on the question of absenteeism. But what the administration has done has provided in each of these health facilities attendance register managers, assistants, who physically, I prefer calling it mechanically, manage attendance registers so that we can have a basis for sanction those who are a problem. But of course, the softer approach is to mindset change, which is the better approach to make sure that the staff are available to provide the services.
Thank you. Dr. Nathan.
Yeah, I'll talk to a few of the questions. Richard, you'll talk to male involvement from the angle of GC. So challenges, Dan. This is a very loaded question. The journey definitely has been a journey that is full of challenges, if I could call it that. And they are broad and at different levels. And I will limit myself to Kampala. I will not go to the national level for reasons that you may understand. So the number one challenge or challenges, the wide systems gaps across all elements of the healthcare system. As Dr. Wondo has described, the system which is entirely pivoted on one, private sector serving very many people who don't have the resources, but then they will end up, some of them, going to the public facilities and congesting them. So the overcrowding of public facilities that do not have enough stocks, do not have enough human resources, personnel, 24 hours, do not have enough equipment, do not have enough space. Actually, that's a very big problem. So across the healthcare system, that's a huge challenge that we meet or we met from day one until today, actually. So what have we done about that wide systems gaps, cutting across? One, partnerships, strategic partnerships, because the resource envelope that we had, thanks to the American people from USAID, was limited. And it also has boundaries, because there is agreement between the two governments. So strategic partnerships. We are not able to buy many equipment, pieces of equipment, high level, low level, ordinary, but other partners were able to do that. For the small equipment that we were able to procure, we procured. Say nutrition equipment, anthropometric equipment, basic equipment here and there in the clinics, we were able to do that. When I say systems gaps, I also touch on human resources for health. Numbers, and I described what we did in the circumstances, but a lot more still needs to be done. Skills, competences, I think we've largely done a lot of that because that was in our control, really. The other gap that still touches on governance, stewardship as part of the healthcare system, of course, appreciation at all levels, not at your level, sir, so please, all levels, there is governance at all levels, healthcare facility level, community level, leadership and governance. But we dived into those areas and were able, with the stewardship of KCCA, to clearly define roles and responsibilities for leaders at various levels to be able to take up the mantle, including community level, actually, What is the role of the LOC chair? What is the role of the religious leader? Very interesting that we actually discovered many healing informal groups within the city during the COVID and Ebola response that we were not aware of, that people are really congregating around them, and they have their own leadership hierarchy. But through engagement, those leaders were able to actually appreciate their role, specifically around infection prevention and control within their own congregations, including the churches, these big churches that we have in the city. So that was within our control to a large extent, and we were able to have some mileage around that. Engagement and negotiation. That's the other avenue that really helped us. And that has to be sustained. The learning was that has to be sustained. Engagement, negotiation, building relationships at all levels, and can start from the national level, but also KCA level, City Hall, division, and many times would make some mistakes around that. Truth be said, you could jump protocol without you realizing that you've jumped protocol, and therefore you are not able to move all the mile, and you got to come back and check the boxes and then go back. In our engagements with traditional institutions, in Kampala, we are the center of a huge traditional institution, which is very useful. So we found a way of leveraging it from the leadership side so that those structures can actually lend us their voices at the, for example, Bulange level, and then I've forgotten the word in Uganda, the chiefs at the lower level. Those are actually very useful. I never knew that they were actually chiefs within the kingdom that can actually go a great distance. Okay. Yeah, in helping with health issues, public health issues. So it's a multi-style kind of approach that we adopted. Dynamic, thinking on your feet, but also being able, to agree that you're going to fold your sleeves and make your hands dirty.
Thank you, Nathan.
Yeah.
Now, just to the point, Agnes, any question to respond to? You just make it brief.
I think most of the questions were around Kampala, but I want to speak about the general sustainability approach, where we worked very closely with the government of Uganda structures to strengthen the systems. Just to probably take an example, we worked to strengthen the technical working groups, institutionalizing use of data, as opposed to doing the work, working alongside with our colleagues to ensure that they can continue doing this even when we're gone. Over to Dr. Richard.
In a second, Richard.
Yes, I think Dr. Mungera spoke to the male groups. And just to add that for us in Kampala, we've worked also with the male champions, especially in the community work around community nutrition and birth preparedness, to make sure that the men are accompanying their women where possible. We have, as I said, Kampala is dynamic. Time poverty, men are unavailable, but there's been some traction around that, and I think it complements the work that you've been doing.
Excellent.
Yeah.
Excellent. Now, 1 second, Dr. Ali, your question, just to the question. To the question. Because previously we were doing well with time, but now we are doing terribly with time.
Thank you, Chair. Mine goes to Kampala, and I would like to thank Nathan and team for the great work done in Kampala, especially at the hub in Kawempe. But our biggest challenge is about the referrals, and those that have been referred through the pre-referral communications coming in an ambulance. But what can we do about the paramedics? In our third Safe Motherhood conference, we talked about paramedics training. Since now we have emergency medicine, how far has that gone? Is there a plan? We need people with these patients in the ambulance, giving them treatment as they reach the destination.
And that is
That's
to
my question.
Dr. Owundo?
Yes.
Dr. Owundo, that's your question. My sister here, question number 2, just to the question, okay? And you mentioned to who the question is being directed.
So thank you so much. My name is Dr. Wangoi Muthigani from Kenya. I work with Gates Foundation. And I'm really pleased to be here to learn so much from Uganda. And this question is actually to you, Dr. JP, on...
Oh.
I mean, I'd love to hear from you on what your thoughts are in terms of introduction of innovative, high-impact interventions, such as the emotive bundle, the multiple multi-nutrient supplements in ANC, and CPAP for neonatal resuscitation, just given that a lot of the issues now that we are seeing in MPDSR in Uganda are on PPH in the facilities, anemia in antenatal, the antenatal cycle, and birth asphyxia.
Excellent. Now that's me. It's my sister from the Acholi local maternal neonatal system, Dr. Baifa. And that is the third one. And I had the last one right over there. Other questions, you will interact with the panelists during lunchtime. My sister.
Thank you very much. I want to appreciate the innovation of the NASMEC. I think we've seen experts reach the last mile midwife. I was very happy when Professor Annette Nakimuli came up to Gulu in the name of NASMEC and met the last mile midwife. They were very excited to meet her. And then the LMNS is working very well so far. And I must say the LMNS has strengthened the governance roles of the regional referral hospital very greatly. However, the challenges that we are grappling with is the absence of critical cadres. We cannot save babies from dying when all the general hospitals in Acholi don't have a pediatrician, and they are delivering over 300 babies in a month. That is one big challenge that we are struggling with. And then 2, the emergency medical services ambulance. To my view, as the LMNS coordinator for Acholi, I'm speaking for Acholi, they have not yet met the need of the very sick newborn. The midwives still confess that ambulances seem to respond more to the mother with difficult labor than to the sick newborn. And they still confess, we still have babies coming desperately on a border once in a while, and outcomes haven't been good. No wonder the numbers are not coming down. So we need deliberate efforts to improve referrals for the sick newborn and to have the critical cadres to save the newborns. And lastly, the LMNS coordination, I don't know if it was by plan that it's obstetricians that should coordinate it. I think our counterparts, the pediatricians at regional level, are a bit laid back in the LMNS. So the plea for the newborn is not as strong as it is for the pregnant women. So I don't know if you can create space for them to co-coordinate, or I don't know what it is, but they need to be brought up front as well. Thank you.
Thank you. Thank you. And let's have the last question right over there, and then we close the questions, we get the responses. I think it's Dr. Owundo. I think my sister Baifa just raised a comment sharing her experience from Acholi, so you only have a question. And maybe myself have been fired very tough questions. But let's get from my sister. Yes, please.
Yeah, thank you
in a second, please.
Thank you so much. Odu Felix, a medical officer.
Who are you directing the question to?
I have 2 questions, one to Dr. Owundo, and the other one can be co-answered by Dr. Kajimu and Dr. Nathan.
Proceed.
Yeah, the first one to Dr. Owundo. How were you able to start the implementation of the new health structure to optimize CMOC functionality in KCCA, where now we have increased numbers in Kisenyi, of medical officers, and they are able to perform cesarean sections during day and night. This would help other regions learn from you. The second question is, what mechanisms has USAID put in place to ensure that at all costs, the programs they have introduced like IRR, collaborative, helping babies survive, high-risk clinics, survive and thrive? Because we have seen that when partners leave, these programs tend to end with them. But do they have what they will be doing to ensure that at all costs, this baby that is now walking can run? Thank you.
Excellent. And I'll start with my sister. One, to thank you for coming all the way from Nairobi to learn with us. And I know we have other countries here. And for me, colleagues here, that's very powerful if we are sharing learning across our different countries. There are three things: system, processes, teams. If we have an innovation, if we have a system, a catalytic mechanism that is going to cause change, we must ensure that we have a system in place that is going to absorb that catalytic mechanism. We must ensure that we have the team. The teams must be in place. They must be of a very positive mindset. They have to share the vision with us. And three, we must ensure that we have the processes. The political will is very, very important. So regardless of the intervention or the innovation that we are creating, for as long as we have evidence that is going to make a change, we must ensure that those three are in place, and then the rest will follow. Leadership, governance, and accountability are very, very important. My brother Undo.
Thank you, Chair. Just a quick one to an earlier question on sustainability. We know that a number of interventions, including MPDSR, can not fail to go on because the technical support coming in from FHI is possibly coming to an end. It is not excusable at all to have any reason why we cannot sustain MPDSR. But also under CQI, we know that MPDSR is a key parameter which is assessed. So we intend to ride on all those measures which aim at strengthening service delivery at facilities to ensure that some of these initiatives are sustained. The question on scaling up, remember, for the public PNF facilities, easier to sustain. For the purely private, we have to scale up because there are many. Not all of them are on board. But whenever during this MPDSR reviews, we track the referral route the mother took, and we quite often end up at the private facility where the delays, challenges were. And there's no way we can run away from that. We shall have to do it because we inspect these facilities and ensure that they are compliant. We also have that whip. We can close some facilities, and we've done it a number of times before.
Thank you.
Now, on the question of paramedics in the ambulances, as you are aware, you could be aware that we have a well-described ambulance operation system for Kampala, but we started with what was available. And the first thing was having the call center, having the ambulances, having the dispatch teams on board. We have provided for these cadres in the revised structure which we are pushing, and we think that is the more sustainable approach. In the interim, our call would be to an implementing partner coming on board if they can pick on a paramedic for specific ambulance, because there are not many. We would be able to address that. Finally, on the issue of the structure, I think the question is how did we succeed to get the numbers improved so that we are able to operationalize this, including higher cadres. did a WISN study, workload indicators of staffing need, as a justification, a basis to make a case, for the obvious reason that the numbers are not disputable. We have seen all this in the MOH annual reviews, that we are seeing so many persons. And therefore, the available structure for a normal health center cannot operate in our setting. And this was the basis, and it was easy to justify, and when it was provided with the wage bill, then the Health Service Commission did their work. Thank you.
Thank you. My brother, Richard, you have one in a minute, please.
Yes, so for sustainability, I think we've demonstrated that. And the thing is, the government structures must be in the lead. I know that all of us attend the MPDSR meetings, and you had no idea that MCHN was behind the initial steps. You now have a Zoom link that is offered by the Ministry of Health, so long an FHI 360 Zoom link. That is sustainability. You have Bruno calling you and running after you and reminding you he's not an FHI 360 employee. That's sustainability for me. For IRR Collaborative, still, when we had discussions, they are being led by Chris Ebong from the Ministry of Health and Elizabeth Namagala from SCAP department. They meet on a weekly basis. That is leadership, that is sustainability. The government taking over what we have started.
Thank you. A round of applause, ladies and gentlemen, for this very, very powerful team. And you can proceed and take up your seats. We are drawing to the close of this very, very powerful session, ladies and gentlemen. And without any further ado, allow me welcome remarks from USAID. And they will be delivered by the representative from USAID. The floor is yours, ma'am.
Great. Good afternoon. Thank you for having me here. And maybe I should just remark about the energy that's in the room right now. It's almost palpable that it's a little emotional as we look at all this action that's happened. And I just want to recognize that. My name's Marianne Umbija, and I'm making remarks on behalf of the U.S. Embassy. All protocols observed to our ministers in the room, our directors from the Ministry of Health, commissioners and assistant commissioners, our representative of the Director of Public Health, KCCA, and our heads of agencies across the UN, as well as representatives of our implementing partners, civil society, and of course all of the advocates, the allies, who are all here to support Safe Motherhood. I've come here to represent the United States Agency for International Development. I'm a Deputy Office Director with USAID. As I said, my name's Marianne Umbija. The US government recognizes that a healthy population is a foundation for every country's social and economic development. And therefore, every year, the US government here in Uganda actually invests over $500 million in Uganda's health sector. And I'm pleased to be here on behalf of those investments. Today, actually, we're marking just 5 years of investment and collaboration and efforts for this project, MNCHA, and I'm deeply honored and inspired to be here to recognize those achievements. They're not small, as you just heard from all of those presentations. USAID's Uganda Maternal Child Health and Nutrition activity is full of stories and lessons and relationships and partnerships and results and data and learning that have showed exactly how powerful our dedication can be just by working together to make progress. We thank you for your dedication to safe motherhood. We also recognize at the US government that overcoming barriers to access and use of quality reproductive, maternal, newborn, child, and adolescent health requires resources. And not all districts are similar. We've heard about how the urbanization here in Kampala has really affected how services are delivered. So in response to this, in 2020, USAID actually invested $26 million towards this activity, which will end in December. And it's all about proving health outcomes across Uganda, but especially here in Kampala. And there are 5 lessons I want us to take away, because we just heard so many great and interesting pieces from the experts who have been part of this process. But from us at the US government, there's one, that policies and guidelines are crucial for the standardization, but they really require resources after the development, because after all those debates in the boardrooms happen, we have to get to work to actually implement them across the country. 2, data-driven decision-making really helps target interventions in high-burden areas. All the dashboards and data that's there, we have to keep using it to drill down to where young women need the most support and how we help there. 3, I would say service delivery is tied to strong governance and leadership at all levels. We've heard that directly today. And that 4, a resilient health system can actually withstand adversities. And I want to say for this project in particular, this included COVID-19, Ebola, and even the current Mpox outbreak that we've seen here in Uganda. This project could have been disrupted multiple times, and they not only persevered, they contributed to the response and were engaged throughout, and we really appreciate that. And 5, I think we haven't heard it enough. I think it's going to continue to be a conversation about how we leverage the private sector and those partnerships to continue to sustain the gains. At Kampala's health services are driven by the private sector. And so if we don't figure out how to unlock that, we won't get further to achieve the goals so we need to make. So I'm inspired by the incredible work of our partners, especially frontline health workers. I know most of you are in the room today. These really are tireless efforts and achieving remarkable results. We really are proud to be part of this. And while we have made progress, we do recognize that there definitely is more to be done for small and sick newborns to receive the care they need. We recognize that neonatal mortality has stagnated over the past 15 years, not just the past 5 years, and now surpasses pneumonia, malaria, and diarrhea as the leading cause of death among children under 5 in Uganda. To address this, we really do believe we need to invest more in high-impact newborn care, including neonatal nurses, equipment, transport, lactational support, including human milk banking, and the follow-up of discharged newborns by community health workers, along with integrated community case management and continuous capacity buildings. As partners, we need to continue to align efforts to prevent deaths. And the data tells us that we actually can make progress with quality services because we can address birth asphyxia, prematurity, and sepsis. We have the tools, as we know. On the reproductive health side, I can't not speak about high teenage pregnancy rates, which remain a challenge. I applaud the efforts being made to increase accountability on the issue. And the US government is investing in multiple programs for adolescent girls and young women through the DREAMS platform and also through a group antenatal care model. However, we really think this problem requires a continuous multi-sector approach that involves all of us, whether it's development partners, community leaders, parents, young people, and the ministries to really tackle this root cause of the issue. As the US government, we remain committed to support Uganda's efforts to reduce preventable deaths for mothers and their newborns, as well as drive lasting change for urban, poor residents of Kampala. We will also continue to work with partners to ensure healthcare services supported by the US government are free from discrimination and provide access to all populations, including key populations. And I'm confident that the conversations we have here this week will lead to tangible improvements for mothers and children across Uganda, just as they have in the past years. And I urge the government of Uganda to adopt and sustain the valuable lessons learned from this work, such as the maternal and perinatal death surveillance response, ensuring accountability for the care of every mother and newborn, and utilizing these very effective networks to approach the gaps in quality service delivery, including nutrition, and engaging more meaningfully with the private sector. So thank you all, and I appreciate all your support.
I don't think that's enough round of applause for USAID. I think we greatly appreciate the support that the US government is giving to the sector. Now, finally, colleagues, allow me to invite our chief guest for this session, and that is Honorable Josephine Bebona, the Woman Member of Parliament for Bundibujo, but also very importantly, the chair of the Committee for Safe Motherhood in the House of Parliament of the Republic of Uganda, to give her remarks, and we shall launch our key documents after her speech. Honorable.
Thank you, Doctor, for giving me this opportunity. Good afternoon to you all. I also follow the earlier on protocol, which has been observed by the other presenters. Like they have told you, my name is Josephine Bebona Babungi, the woman MP Bundibujo District, and I'm serving my second term, and I'm also going to look for another one. Yeah. So I'm happy to be here, and I take the honor to welcome all of you. I must say this is a very, very rich engagement. We are having almost, I think, all the partners, all the implementing partners, all the midwives, and all the representatives of different agencies, and also all those who have represented different regions. Thank you so much for taking off your time to be here, and thank you so much for coming to participate in this engagement, where we are all sharing experiences so that we can see how to improve, so that we can see that no mother dies when giving birth, and we also reduce the numbers of the children who are dying in our facilities and in our communities. We thank the government, which is working very closely with the different implementing partners, and which is also working with Parliament, of course, because as parliamentarians, we play a very critical role in shaping health policies, allocating resources, and ensuring accountability. We engage with the ministers because they are also supposed to give us the accountabilities when we appropriate funds for different sectors. Our engagement with them is very essential in driving forward the agenda for improved maternal, neonatal, child, and adolescent health outcomes. And now we are here. The theme today is about community engagement. To me, I think it has been very good. The one who chose it, we really give a round of applause, because this is the time we move away from our towns, we move away from our offices, we move away from our comfort zones to go and engage with the communities to make sure that health, all of us participate in improving the health in our communities. Now, recently we had an engagement with the religious leaders. We're also telling them, go out there and preach the gospel, but again, we don't want any mother to die when giving birth. We don't want the children to die. You know, for them, the mobilization is very easy. For them, the people come to them every Friday, every Sunday, every Saturday. People continue coming to them year after year. So their engagement with the communities, talking about health issues is easy for them. Unlike for us politicians, when you call for a meeting, you know what it means. But we also have different forums. We have very many platforms at barriers, at functions. We can also talk about it. We are also encouraged, and we encourage our colleagues to talk about health issues and so many other things. We are also engaging the cultural leaders to talk about health issues. So all of us are working with the communities. I must commend all of you who are making sure that we work with the community to reduce the numbers, to make sure we improve our health systems, not only waiting for government efforts, not only waiting for the funding. We can prevent at community level. We can prevent even with, at low costs, by the way. As we allocate these budgets, as we allocate these funds as members of parliament, sometimes we are let down by government. Sometimes we have the gaps, the insufficient funds because of the budget cuts. So when the government fails to implement the signed instruments, let's say, for example, we can say we want the health budget to be at this %, and we fail to reach that %. That means we are failing to implement the signed instruments. So the gaps will remain there, the challenges will remain there, but all the same, we cannot get tired. We shall continue talking, we shall continue engaging all the agencies so that we see where to close the gaps. Now, so many presenters have presented, and I only noted some of the few things. For example, there was an issue of follow-up after discharge. Follow-up after discharge. But what of on admission? Are the midwives, are the health workers there on admission? The issue of absenteeism came, someone talked about it, but it is still also a very big challenge. I am the midwife who is an MP and who is hands-on. I'm always proud to be a midwife. I've always been proud. I am the midwife who trended on social media and on TV in 2019, the midwife who delivered a baby in Chikube district. We were on field visit. It was around 4 p.m. And this was a health center but there was no one on duty. So because the houses for the midwives are within the facilities, or they will think that they are on duty, there is no one, like the duty is not busy, and they step out. But here comes a mother who is in the second stage of labor. You know what it means. And this is what exactly happened. I had to swing into action, quickly rushed, put on gloves, put the mother on the bed. By the time I prepared the instruments and what to use, the baby's head was out. And what could I have done? I delivered this baby very successfully. And by the time the midwives came around, we were there breastfeeding our baby in bed. Yeah. So sometimes absenteeism, the way we attend to our duties is also very, very important. And since then, I have not stopped delivering mothers. I have been a member of parliament now, coming to 10 years, but when I'm in the village, in my constituency, I continue doing these services to the mothers. Because before I joined parliament, I served for 18 good years. I have seen some of my OGs around. Welcome and thank you for coming. So they were telling me, now you cross to politics. I said, but still, the skills are still in my hands. Because I believe even when I leave politics, I can still continue to help out these mothers. Now, the issue of teenage pregnancies also came out, and it is still a challenge to all of us. That is why we are engaging the cultural leaders, the religious leaders, and all of us. And for me, as Rwenzori sub-region, we still have, I think, very, very high numbers on top of the Busoga region. I think it also has high numbers. But we are still continuing to talk to the parents, talk to the teachers, everywhere. And not only to talk to the girls alone, but also to talk to the boys. Because this teenage pregnancy is caused by a boy or a man. In most cases, they are They are young boys, not yet even to the age of taking a woman in, you know. So that is still a very big challenge. But I know with all of us putting our hands and heads together, we shall make it, and we shall see how to improve on the various gaps which we have identified. And I know from this conference, all of us, at least someone has gotten a message or something to learn or something to go where we are working and improve on those gaps. As we also continue to engage government to make sure and continue pushing a little bit on our budget allocations for the health sector. Now, I'm here to officiate on the national launch of some of the documents which are going to help us as we continue with our work in our communities. And I take the honor maybe to call upon, I don't know whether Doctor is the one who is going to tell me people who are going to join us so that we can launch these documents and therefore be disseminated to various entities. I thank you so much, and thank you for listening.
And thank you very much indeed, Honorable. Honorable, you could just stand at the front as we prepare to launch. And ladies and gentlemen, as we position the documents, I would request to have the USAID representative at the front, KCCA representative. Let's have the MCHN team. Let's have Dr. Dan Murokora from MOH, the chair of ADHOs. Let's have the chair for DHOs. Let's have the conference chair. Let's have Professor Pius Okong, the chair for the health committee. Let's have a representative from ELMA, WHO, UNFPA, and UNICEF, and we take on this very powerful process. Yes, we're just going to sign against the documents. Yes. Dr. Kenneth, let's have the markers. Let's have the markers. Very good. And my brother, Deo, you will come and just say a little bit as we sign the documents, just say a little bit about each and every document. Let's also take that as a very powerful photo moment for us.
Okay, yes. Thank you, Dr. JP. Good afternoon, everyone. I want to stand on the existing protocol. I want to take this opportunity to present to you the key documents that we are signing off today. First, the newborn situation analysis, which is a comprehensive report that has been developed by the Ministry of Health with support from our partners, led by the Makerere School of Public Health team, highlighting the key gaps and areas of improvement needed for the country to reduce newborn mortality. We know that we have made minimal progress in reducing newborn mortality, currently standing at 22 per 1,000 live births. And we need to move twice as much as we've been moving in order to achieve our target of 12 per 1,000 live births by 2030. So this report highlights the recommendations that we need to take as a team in order to be able to achieve this target. The second document is the National Implementation Strategy for the Newborn and Child Health. This is a revision and update of the Child Survival Strategy, which was developed from 2010 and 2016. We know that through this strategy, we are able to reduce the different areas that were highlighted in this strategy. We are able to contribute to the reduction of child mortality from 90 per 1,000 live births in 2011, current at 52. But again, more needs to be done. But most importantly in this strategy, we're also focusing on the aspect of child development. As we are continuing to reduce more child mortalities, a lot of effort is needed to be put in the way how these children are developing in order to be able to realize their maximum potential. The third document is on the USID MCHN legacy documents. I think we have had a presentation from Dr. Agnes and the team. And at this moment, I want to take this opportunity to congratulate Dr. Nathan and the MCHN team for successfully implementing the MCHN project and the great support that you've offered to the Minister of Health. Great appreciation to all our partners, UNICEF, USID MCHN, ELMA, WHO for supporting us in having this work produced. Thank you.
Well, amazing. Just quickly, all participants of the program STM at UCU Mukono University, let's kindly meet at the entry at the photo booth. We'd like to take a quick picture. All participants of the program STM at UCU, kindly meet at the entry for a group picture. Okay, we're now going to have a photo moment after the signing. We're going to request our guest of honor please to stay behind with the entire team, and then we'll have a group picture. Picture, and then we shall be signing at leisure when others are done.
Absolutely.
So collectively, let's take the group picture.
Yeah, let's do a group picture and then